Fantastic. Good morning, everyone, and a very warm welcome to everyone who's taken the time today to join us on this Eden Dora Trust Study morning. My name is Julianne Moore, and I'm one of the partners at Irwin Mitchell, and I have the pleasure of being your host at today's webinar. As well as being a partner at Irwin Mitchell, I'm also a very proud trustee of the Eden Dora Trust, a charity who I've worked with for a number of years. On today's seminar, we're going to look at how we can proactively help and support children and their families who have an acquired brain injury after encephalitis. We do see through the work at the Eden Dora Trust, in the way that we support children and families who've suffered an acquired brain injury, the devastating impacts that childcare encephalitis and acquired brain injury has on the lives of those children and those families and those who interact with the children as well. Today, we're also going to hear from Patrina Sill, who's the Chief Executive Officer of the Eden Dora Trust, a little bit more about the charity, what it's done to proactively support children and their families, as well as support to healthcare professionals and educators and the like. And we're hoping with this Eden Dora Trust webinar this morning, we can raise some more awareness about childcare, encephalitis and acquired brain injury, that we're all going to come away with some shared learning regarding improving outcomes for those children and their families and people whose lives have been touched by encephalitis and acquired brain injury. I'm pleased to say we have an absolute fabulous panel of industry experts who are joining us today on this webinar. They've all given their free time to help spread that awareness and improve outcomes. And today we're going to cover a few topics. Firstly, what encephalitis is, what it can lead to, how it looks, and the hidden disability of acquired brain injury. Then we're going to move on to how we can work together to support children and young people after discharge from hospital, returning to the education setting post-encephalitis and acquired brain injury. We're then going to look at sleep-wake disorders following acquired brain injury before we move on to a child's world after encephalitis and acquired brain injury. And then finally, some discussions about the charity from Patrina Sill. So just to set out the running order of today, I'm pleased to introduce our speakers. So our first speaker will be Dr. Santosh Mordekar, who's a consultant neurologist at Sheffield Children's NHS Foundation Trust. We've then got two fabulous speakers, Drs. Bennett and Emily Talbot, who are both consultant clinical psychologists at Nottingham Children's Hospital. We've then built in a short comfort break before we move on to our third speaker, who is Dr. Heather Elphick, who's a consultant in paediatric respiratory and sleep medicine at Sheffield Children's Hospital. Our fourth speaker is the lovely Beth Wicks, who's an educational consultant and also chair of the International Paediatric Brain Injury Society. We then have another short comfort break before we move on to hear from Patrina Sill, who's the Chief Executive and the founder of the Eden Dora Trust. And then finally, we've built in a question and answer session, which is your opportunity to ask our fantastic panel of experts any questions or issues you want to discuss. So thank you for those people that have already submitted questions. And because obviously the webinar is in quite a condensed time, there won't be time to ask the individual presentators questions after their individual sessions. So what we've done, we've created a panel discussion at the end of the webinar, so you can submit your questions through the question and answer function, the chat function on Teams, which then we can have a look at, and then we can obviously present those questions to our speakers at the end. So I do encourage you, as the seminar is going on and the talks are going on, please submit those questions, and then we can use those in our question and answer session at the end. If you can also, when you're submitting those questions, include your name and email address. So if we get lots of questions and we haven't had time to answer them, we can hopefully respond directly to you post-event. Just a bit of housekeeping. If you can keep your microphone on mute. Also, we'll be recording this webinar, and it will be sent out to everyone who's registered and signed up directly after the end of the webinar. And finally, we really be helpful if you would We'll be posting a feedback link at the end, and if you can spend just 2 minutes just giving some feedback on today's webinar, and also be really helpful about what further topics you'd like to hear from the Eden Dora Trust, so we can look at doing some further webinars which might be beneficial for everybody. So that's enough from me. As I say, I think we've got a great morning in store, and I have absolute pleasure of introducing our first speaker, Dr. Santosh Mordekar, who I say is a paediatric neurologist at Sheffield Children's Hospital. So he's going to talk to us about what encephalitis is, what it can lead to, how it looks, and he's also going to touch on the hidden disability of acquired brain injury. So I'll hand over to Santosh now. Thank you.
Thank you, Julianne, and it's been a pleasure to be associated with Eden Dora Trust and to work with Katrina and you all. And what I was going to talk about was acquired brain injury. And I specifically titled it as Something Is Not Quite Right, because I've been involved, and with my colleagues in Sheffield Children's Hospital, we have got a big rehab team, and we are involved in managing children with acquired brain injury. And some of them do a really good physical recovery, but cognitively, they do not make the full recovery. And when we review these patients in our outpatient clinic, they'll come and say something is not quite right. The child was not what he was before. And so I was going to cover a bit about it. Next slide. So I've got only over 25 to 30 minutes, so it's a broad topic. So what I thought, I'll split it up into definition. What are the causes, or what do you mean by acquired brain injury? What is the causes of them? Neuroimaging, how does it help us in terms of making a diagnosis and cause? And is it possible from the neuroimaging which is done, or scans which are done, can they help us in predicting some cognitive outcomes or not? And then I'll talk very brief about outcomes, but what I'll do is I'll set up a tone so that my speakers who follow me will pick them up in more details. So next slide. So what acquired brain injury means, it's actually just an umbrella term for describing any injury which is caused to the brain, which happens after the birth, after a period of normal development. So we're not talking about something which has happened antenatally or at birth, like which is called as congenital causes. So any child or young person who gets a kind of insult after a period of normal development. So it could be after a couple of years when you unfortunately get a meningitis or encephalitis. It could be after a period of 4 or 5 years when you get an infection or a traumatic brain injury. Anything which causes and affects and leads to an injury which will affect the normal development, that is what is acquired brain injury means. Traumatic brain injury is one of the causes of ABI, which is acquired brain injury. And ABI is one of the commonest causes of significant mortality and morbidity in children and young person. If it's not recognized, it can cause into future problems. So next slide. So what I thought was, let's go to what are the different causes of acquired brain injury. So next slide. Next slide. So in terms of infections, any kind of infection to the brain and its covering, so any kind of meningitis, meningoencephalitis, viral encephalitis, anything which affects cerebellum, cerebellitis, all of them will lead to an acquired brain injury. I'll show you a few of the scans of my patients and what they are. So next slide. So this is one of my patients who came in a few years back now, and what she came in with a fever and a one-sided convulsion. Intermittently, she was not back to her usual self, so she came under the general pediatricians. They did the right thing. They went on, did her scan, they did her infection screen, they did the full lumbar puncture. And she went on to have, sadly, herpes encephalitis. And what you can see is that, I don't have a pointer, but you can see the bright part which is on the left side of the screen, which is the right side of the child. So she's got a right temporal lobe affected, and that caused her to have a lot of seizures, a bit of swelling, and she then recovered from it, and she then went on to make a good physical recovery, but did have problems with very difficult to control seizures and also cognitive problems. So when she went home, the parents said, this is a completely different person whom we had prior to that. And that is what is mostly said about. So this can happen. So this is one of the infections. Next slide. So this is another patient of mine who had an enteroviral infection. An enterovirus infection is common in our population, but sometimes it can go and cause enteroviral infection with affection of your cerebellum and your meningitis. And this particular boy went on to develop swelling of cerebellum, which is the back part of the brain, and that caused him to not have much of a motor problems, but significant problem with mutism. So this was a boy who could speak absolutely well before. Following that, he suddenly became mute and he just couldn't speak. So he tried to talk about non-verbally, and it is now well described. So it's called medical mutism, which can happen, a selective medical mutism, which can happen in children who get cerebellar infections. And then this gradually recovers, but it never comes back. So what the outcomes are that by 6 months of age, the children recover to have the speech. It comes back about 60 to 70%, but they still have problems with understanding of speech. So they can get dysarthria. In addition to that, because cerebellum is to do with cognitive functioning, they also get a lot of problem with executive functioning, which came out in this boy subsequently quite late on in life when he became in an adolescent age group. Next slide. So that's one group of infections. So any kind of infections can cause them to have acquired brain injury. The typical presentation usually is the same like the next para-infectious group. Next slide. So in this group, you have got conditions like ADEM, that is acute disseminated encephalomyelitis, a range of acute autoimmune encephalitis, and then multiple sclerosis. So in these group, what happens is that you get an infection, your antibodies start producing the infection, and the body starts producing antibodies to tackle the infection, but sometimes can attack your own brain cells, and that leads to these things. So you have got ADEM, autoimmune encephalitis can lead to a range of anti-neuronal antibodies, which can cause anti-NMDA receptor antibodies, anti-MOG antibodies, Hashimoto's encephalopathy, and a range of them. And finally, even with multiple sclerosis, in children, if you happen, they are now reporting that with treatment, people are having a lot of problems with cognition, mental health issues they can have, even though they are making reasonably good physical recovery. Next slide. So this is one of my patients again who came in with a viral infection 2 weeks back. He came acutely very unwell with a seizure and a low Glasgow Coma score, which is a score used for gauging conscious level. So he then needed admissions to intensive care unit, and this was his MRI brain picture. And if you look at it, the white spots on the brains, which you can see, are the areas which are affected. So he had a lot of problems with managing airways, so needed intubation and ventilation. We needed to treat him after the diagnosis was made with a high dose of steroid, following which he went on to make a reasonably good physical recovery. But after about 2-3 years, it was increasingly becoming clear that he was not keeping up with the educational progress, and cognitively he was falling behind. Next slide. So the next group is trauma. Next slide. So trauma could be either accidental or non-accidental head injuries. So there are a range of them, and that is very well described. So there's a whole group of them which can present with a mild, moderate, severe head injuries or non-accidental head injuries. And even in the mild head injuries, we know that these children can mistakenly make a good physical recovery, but cognitively they can have a lot of problems later on, and neuropsychological testing has been picked up in them, and that, if it's unaddressed, can lead to educational deterioration and or poor progress overall in their life. Next slide. In vascular group, even though you get a range of strokes again, venous thrombosis, you can get vasculitis, all of these will lead to, again, an acquired brain injury. Next slide. So this is one of my patients who had a right-sided stroke, a middle cerebral artery infarct, and you can see the part of the brain which is affected. So that also child, he went on to make a really good physical recovery, but cognitively the parents were very clear that a boy who was very organized became suddenly had a lot of problems with planning movement, executing functioning, complex tasking. He was struggling with them. Next slide. And finally, even tumors, next slide, tumors like in the cerebellum and in the cerebral hemispheres, in areas which affect cognitions of frontal lobe, parietal lobe, or any of those cerebellar regions. If you have a tumor which is there that disrupts the organization and pathway, those people will go on to have a reasonably good physical recovery, but will go on to have a lot of problems with acquired brain injury causing cognitive issues. Next slide. So this is one of the patients who developed a cerebellar medulloblastoma. So came in very acutely unwell with headaches and vomiting through A&E. And this was a scan which showed, and it was quickly seen by my oncology colleagues and neurosurgical colleagues. And they treated the child and got him operated. And after that, in the neuro rehab point when he was referred, so he had a lot of problems with planning and executive functioning. The behavior was difficult, sleep was difficult, all of these issues. And educationally, he was top of the class. Suddenly, as years went on, started going to medium and lower end of the class because of the cognitive issues. Next slide. So if moving on to the, how does MRI help? So we know that MRI brain scan is helpful in identifying a cause in acquired brain injuries, whether it's an infectious etiology or whether it's a para-infectious etiology. So we have published at Sheffield with my colleagues a few papers on this, how it is helpful in identifying and how it helps us in planning investigations and getting to the bottom of diagnosis. Next slide. So these are the few of the conditions which I've already shown you. So this is a post-infectious cerebralitis which just happened following a chickenpox infection, and the child was presented. He came in with not much of a cognitive problem, but he came in with an unsteady gait which came in, and that usually comes after the chickenpox has come and gone, and 2 to 3 weeks later. He again did not have much problems initially, but clearly as the child grew up, the parents said that, he is falling with the school work, and he never acquired ABI clinic, acquired brain injury clinic. Cognitively, he was picked up to be falling behind as he was before. Next slide. We also can get a diffuse encephalitis suddenly with the brain swelling, and with the tight skull, it can cause you to have herniation. If you can see, the brain is trying to pop out from the lower end of the upper end of the spine, and that is the time you have to very acutely get our neurosurgical colleagues to try and relieve the pressure, but otherwise it can be fatal. So these also can be fatal encephalitis. You have to be very quick in action of them. Next slide. What is known now, and what is now becoming more and more clearer, that MRI brains can also be used to find out the cognitive outcome after a period of rehabilitation in children with acquired brain injury. So this is a really good paper which was published last year, and what it showed was they tried to look at, can we identify a specific pattern of findings on the MRI scan, and can they help us in predicting the outcome cognitively in the long term? So next slide. So what they did was they used an advanced MRI technique called as a DTI, or diffusion tensor imaging. And what it does really colorful pictures it takes, and it does the tracks of the do the tractography, which looks at the tracks of your myelin, and the way the messages are sent from your brain to your spinal cord and to your arms and legs. And they look specifically at corpus callosum, which is the thing you can see, I can't point out, which is there. The green part is the body of the corpus callosum, the blue part is the genu, and the red part is the tail of the corpus callosum. And the next slide, the middle picture which is there, is exactly the coronal section, as if you're looking at it from the front, and you can see the green part. So what corpus callosum does, it connects the two cerebral hemispheres of your brain and passes on the information to each other. And the next picture is the one which is axial. So it's taking from slices of your brain from bottom to up. And that also shows you the pictures of the corpus callosum. What it looks at and what we found and what is well described, that if you get on a brain a diffuse axonal injury, in which the axon pathways, the axons of the body of the neurons are affected or shaken or disrupted, these are the children specifically who go on to make a mistakenly really good physical recovery, but you have a lot of cognitive problems. So next slide. So what these group did was they looked at looking at this specific test called VFIM, which is the functional independence measure for children. And what they looked at specifically was doing this test. And this test looks at three aspects of it. So it looks at the mobility part, it looks at the self-care part, and look at the cognition part. So in the mobility part, it looks at whether you can manage stairs, whether you can walk independently or you need a wheelchair, whether you can do some transfers in bath and toileting on your own or you need help. And the self-care part, it looks at whether you can maintain activities of daily living. So eating, brushing your teeth, feeding yourself, dressing, undressing, toileting, bladder and bowel continence management. And it also looks at cognition part. So it looks at memory, executive functioning, planning, processing information, expression, social interaction, etc. And what they did was, the example they've shown in this graph is of a 10-year-old boy who had an acquired brain injury, was quite unwell when he came in and needed inpatient rehabilitation for about 175 days, so almost 6 months. They did a VFIM at admission, which is part of the blue, and on discharge, which is in green. So if you look at it, the admissions, the blue part, he could hardly do anything. He could hardly feed himself, hardly move. He couldn't do that. But at a time of discharge, when they do that, at the green part, if you look, he seems to have made a really good recovery in the self-care skills, mobility skills, but in the cognition area, there are deficits, and the deficits are in problem solving, memory, expression. So what this paper highlights is that it is extremely important to understand that even though patients who make this recovery can have a lot of cognitive issues, and they need to be carefully watched for and kept under supervision. Next slide. So just moving on to outcome, because I've got just 10, 12 minutes to talk about it. So a lot of focus tends to be done on the physical disability and improvement of that. And that's right, because that's what the more focus is on. And the cognitive or the hidden disability, which I've called, is missed in children and young people. And why is that? Next slide. And that's because there are some myths about ABI in children. I think there is an incorrect optimism which still persists in some region. It's well recognized now, but it still persists that the outcomes for childhood ABI are generally superior to those in adult ABI. And that's based on some naive concept that there is a greater plasticity in the immature brain. But actually, the truth is that the child's brain is much more vulnerable to traumatic injuries and has got a poorer outcome than the adult injury. And that's because the injury is happening at a time of critical brain maturation. So when you're growing through your years, into your childhood and adolescence, the number of synapses are increasing, and they're trying to coordinate with the areas of frontal lobe, executive cerebellum, parietal lobe, occipital lobe. And if an injury occurs at that time, this stops, and that is where the further progression doesn't happen. Next slide. I've taken this graph from a paper by Rob Forsyth. So Rob Forsyth is one of the eminent pediatric neurologists at Newcastle, and he has done a lot of work in acquired brain injury. And this paper is almost 11 years back, but it's really a relevant paper. So what you look at is at A, B, and C. So what it tells is that if you look at A, the green part, the baseline happens, and after that, if the injury happens at that time of ABI of any kind, there is a dip in loss of skills, and then it slowly picks up. So in the next graph, the B, it shows that if X is the baseline, the dip happens if the injury happens at that time to Y, and then a gradually improvement happens to the Z. Now, if you think of it, say a 5-year-old child, look at the graph C. So 5-year child, if you look at three aspects of his walking, that's gross motor skills, talking, that's speech, and thinking, that's the cognition. If you look at it at 5-year-old, if he gets an injury, he by 8, 9, 10 years, he will quickly pick up and the walking will come up pretty much and to what he should be doing. If you look at the talking, even if you follow the trajectory, because I can't use the pointer, if you follow the trajectory, he will gain his speech, but it will not be to the level what he should be. So it will be immature for his age. But you look at the thinking and cognition, even though he gains the gap between the final year, if you follow the graph, which is there at the Z point, to at 20 years, there will be a lot of difference in the cognition levels at 20 years, because and that is what is important to be highlighted. Next slide. So why are the hidden disabilities in ABI missed? And that's because most of the educational and the behavioral effects of ABI are in the high level cognitive functions, and they emerge slowly over the years. So it does not be picked up immediately. The second thing is the frontal lobe insults, or the deficits of executive functioning, will only come out later on. So you start using your frontal lobe at 11 years plus. You don't use them before. And that's the reason the recognition of these difficulties are often delayed, and they're almost at mid or late adolescence when you will start picking it up. Prior to that, these people will be developmentally silent or neurodevelopmentally silent, because that areas are neurodevelopmentally silent, even in the normal child. And that's the reason it's sometimes missed. Next slide. What is important to know that the knowledge and skills which are learned before the injury, they largely remain intact. You don't lose those skills. But what happens is the children struggle to gain new skills or new learning. And that is not picked up immediately, so in a year. So if you have got something, if somebody started school at say September and gets an ABI in December, it will not be picked up quickly next year, July, but in subsequent couple of years, you will pick that cognitive disability more. What you have to remember, there are also important links between executive functioning and attention control, because attention control span is very important to sustain any information, process any information, and deliver any information. So if you don't have good attention span, you cannot sustain it, process and deliver it. And that is also a problem. So that's why I put in inverted commas, the secondary ADHD deficits of these are very common in ABIs if your frontal lobes are involved in terms of injury or of any kind. Next slide. Then there are other issues with ABI as well. So mood disturbances. So a range of psychiatric problems can be described in ABI. So you can get anxiety, depression, personality change, very well recognized. So parents will say that a boy or a girl who was otherwise very well behaved suddenly becomes stroppy, suddenly changes the personality. There's a mood change happens. Post-traumatic stress disorders are common. ADHD, substance misuse are common. So in these specific group, a multidisciplinary team, including a psychiatrist, psychologist, is extremely important to be sorting them out with the depression, anxiety issues with ABI. I'll not go more in details on it because Dr. Bennett and Dr. Talbot will cover this following my talk about it. Next slide. The other issues which are missed about in ABI are the sleep disturbances. It is well recognized that in children with ABI, they have got lower sleep efficiency, they've got more wake time, they get nocturnal wake, the sleep, the hygiene, the sleep, all the stages are disrupted completely. And that also there is evidence of the pain, anxiety, depression, PTSDs, medications given for ADHD, which are common in these groups, they all have an impact on the sleep hygiene. The other thing is because of the poor sleep that leads to fatigue as well, and fatigue itself is more common in ABI, which is under-recognized. And Professor Elphick will cover this later on more into her talk about this. Next slide. What is then important that other issues in child and adolescent ages is getting back to school. And that is also extremely important because you have to be gradually integrated back to school. If you go in too quickly, the fatigue, if it's not recognized, it puts you back again. So it is extremely important that all those things are considered into it. And what is again important is that it is common that if the injury had occurred while in primary school, it may have not been picked up still so far, and that will also get you quickly, it is misconception the child has recovered, and that information is then not passed on to the secondary school, and that can cause you more of a problem. So involvements of SENCOs, educational psychologists in a setting is extremely important, and most of the SENCOs and educational psychologists are extremely experienced in picking these things up very quickly. So their involvement is very, very important for this holistic management of all these children, and Beth Wicks will cover more into this. Okay, so next slide. So what I was trying to just set up a scene for today's morning. That first thing is important, that the misconception that the childhood ABI has got a better outcome than the adult ABI needs to be taken out of our picture. We need to recognize that childhood ABI has got, the children are much more vulnerable than the adults who get an ABI. You need to be, understanding this message needs to get across, although it's getting across now quite well now. The other thing to remember is specific cognitive functions continue to develop throughout the childhood. And as it is impossible to examine a function that has not yet developed, short-term follow-up and assessment does not exclude the cognitive and behavioral difficulties at school age. So, for example, if you've got a 5-6-year-old, you cannot test him for frontal lobe or executive functioning because it's too early. He will not be able to do that, and that's the reason of keeping these children under follow-up, either under community pediatricians or neurodevelopmental pediatricians or under ABI clinics is very important. And if the hidden disabilities miss, sometimes it's missed, and that unrealistic expectations of the recovery, sometimes can lead a lot of problem in the educational setting for these young people, and subsequently later on in employment failure in the adults. I'll stop there, and thank you very much for listening.
Thank you so much, Santosh, for that absolutely fantastic talk. I know actually it's such an in-depth subject, and you could probably spend a few hours, couldn't you, just talking about it. So actually to condense it down into the time you've done, absolutely, it's absolutely brilliant. So that was really good. Lots of questions coming in, so continue to obviously post those through, and just want to say thank you very much, Santosh, for your fantastic talk. So now we're moving on to our second speakers. We've got the pleasure of having two speakers, both called Emily. So we've got Emily Bennett, who's a consultant clinical psychologist at Nottingham Children's Hospital, and also Emily Talbot, who's also a consultant clinical psychologist at Nottingham Children's Hospital. And the Emilys are going to talk to us about how we can work together to support children and young people after discharge from hospital to return to education post encephalitis. And we've seen how important that is and how crucial that is from Santosh's talk. So I'm going to hand over to both the Emilys now. Thank you.
Thank you. So hi, I'm Emily Talbot, and my colleague Emily Bennett will be speaking shortly after me. So we're going to be talking today about working together to support children and young people after discharge from hospital in that very early sort of stage and return to education post encephalitis and ABI. Next slide, please. So Santosh has talked about kind of ABI in childhood and adolescence and given some introduction, but just to kind of think about that within the context of what we're talking about today, we're thinking about that ABI as that injury to the brain that happens after birth following a period of normal development, happening to any child or adult at any age. And as mentioned, including a range of different reasons for that injury to the brain, that may include traumatic brain injuries, encephalitis, and just highlighting that huge range that there may be in terms of outcome from that ABI, ranging from a mild head injury, concussion, to a very severe brain injury that may have impact, kind of lifelong impact. So prevalence is estimated that around 40,000 children are seen at hospital per year with an ABI, though this is likely to be a huge underestimate, and of those, approximately 2,000 will have sustained a TBI, 3,000 a moderate TBI, and 30,000 a mild TBI. So and around 5,000 others with an ABI as a result of illness or infection. So for children in the UK, the average number of hospital admissions for encephalitis is around 6 in every 100,000. And when we're thinking about ABI, we're thinking about that return to education and just thinking generally about schools and providing that learning environment for children. Research has actually suggested that around 1 child per class will have experienced an ABI of some kind by the time they complete education. So it's really important that schools and education providers have that awareness and understanding of ABI with that kind of level of prevalence. Next slide, please. So in terms of thinking about that impact of childhood ABI, we know that it can result in a range of difficulties, and this slide here is just highlighting that huge range of difficulties that children may face following an acquired brain injury. We're looking at the kind of cognitive areas, so that sort of speed of processing of information, attention and concentration, executive function and memory. We've got that area of social and communication, kind of expressive and receptive language, their competence in their social situations, those social skills and conversational skills. Looking at kind of emotions, so children who may experience anxiety or low mood, difficulties around self-esteem and confidence, and anger and frustration that they may experience. We see difficulties within the area of behaviour, so children may present with difficulties with disinhibited behaviour, impulsivity, so finding it very difficult to hold back and not respond in that moment to something that's happened. Thinking about insight, so how much awareness and insight do they have to the difficulties that they now face. And some children may display some level of aggression and difficulties with managing and controlling that behaviour. And physical and sensory, so we know that some children may have some difficulties with motor abilities post ABI, difficulties with dexterity, motor planning, and sensory difficulties, so some children may have hearing or sight impairments. We know that children are very individual, so in terms of some of these difficulties may be more apparent for some children with encephalitis, and for some there may be very few of those difficulties that they may present with, whereas others may experience difficulties in all those different areas. And one of the biggest areas that we see is also fatigue, and we're going to go on to talk a little bit more about that, because we know that that fatigue that children face following ABI can have an impact on all aspects of a child and young person's life. And what we're looking at when we're thinking about highlighting and finding where a child's areas of difficulty and strength are after an ABI is we're looking at those different areas of life that may be impacted on and what we can do to support them in their rehabilitation in those areas. So thinking about their learning and education, thinking about their hobbies and their pastimes, linking their friendships and their relationships with other people, and their future life and identity, and that general participation in all of those aspects of life, which we want to be able to support a young person with. Next slide, please. So that slide highlights all of those different difficulties that a child or young person may face at different stages following an ABI. What we're going to just focus on more today is those very early challenges following discharge from hospital, and some of those those things that we more frequently see in those very early stages as we're discharging children and they're returning to education. So one of the things is sleep that we see in those early stages, and there may be lots of reasons why children are experiencing sleep difficulties in that early stage, and Heather will be talking about that, so we're not going to go into detail about that, but just to highlight that that is something that we will frequently see and talk to families about in those early stages. Other difficulties are the changes in personality and behaviour, and we'll go on to talk a bit more about that and the reasons for why that might be. Fatigue, as I mentioned, and for a number of children post encephalitis with an acquired brain injury, they may be experiencing seizures and go on to have a diagnosis of epilepsy post ABI. Next slide, please. So just to talk in a little bit more detail about the behaviour and personality changes that some children and young people may present within that early stage. This is one of the areas that I think families can find the most challenging, really, because as was mentioned earlier, is that just that sudden change in the presentation of that child. So parents will say, you know, my child just is different to how they were before, and that's really hard to kind of manage and to understand and to adapt to. So we may see that children have lower tolerance levels in kind of managing things that happen. So maybe changes that are happening, maybe they find that much more difficult to deal with than they did before. Those difficulties in managing their emotions, so they may become more quickly anxious in certain circumstances and situations, or quickly they may feel frustration of something and maybe quite quickly flick into feeling quite angry and kind of lashing out in that way. Finding it difficult to manage conflicts. So you might see this in those kind of family dynamics where actually you may have siblings who previously generally got on quite well, maybe had those general sibling little squabbles at times, but actually you might be finding that actually now they're just finding that much more difficult to manage and not able to kind of find those resolutions to some of those things that are happening in the family environment. And some of those things may also be impacted upon by a young person's insight. So for some children, they may have that insight into the difficulties that they now face, that they may see those differences in how they're doing things. They may have an understanding that they're finding things more difficult in terms of memory or concentration. They may be finding that they've got those physical difficulties that they're kind of having to adapt to. But for some young people, they may not have that level of insight. There may be difficulties in them being able to see that. And so being able to talk to them about that may be quite difficult. For some, they may have those fluctuating periods of awareness and engagement as well, so that insight might change, and that might be in relation to, for some young people who may experience seizures, that may be related to that, but also it might be related to fluctuations in their levels of attention and concentration, and in those very early stages, just in terms of kind of general fatigue and kind of awareness. And then, as I briefly mentioned before, is that sort of impulsivity and disinhibition. So it may be that you have a child who previously maybe was a little bit more shy and a little bit more reserved, and actually this young person now presents with much more kind of disinhibited behaviour. So they may be more likely to go up to someone that they don't know and start a conversation with them in a way that you wouldn't have expected before, or they may react quite quickly to something and say something which actually you might think, oh, that's a bit rude. They may respond in a different way to how you would have done before, and that might be related to the emotional impact of what they've been through in terms of such a significant event, being admitted to hospital and experiencing a significant illness, and also maybe related to some of those executive function difficulties that we might see for children and young people post ABI. And obviously these changes have a really significant impact on family, friends, school and community access. And so it's something that we would be wanting to kind of really look at and think about in terms of supporting that young person and that family in their discharge home and in their return to education. Next slide, please. So talking about fatigue. So fatigue is, as we've talked about already, very common after acquired brain injury. And when we talk about that fatigue, we're not just talking about that kind of physical fatigue that you might feel when, you know, you've kind of done a really hard gym workout, or, you know, you've had a long day, but we're talking about a level of cognitive fatigue as well. These are children who they might get a really good night's sleep, but actually their brain is having to work that much harder. Those difficulties, those cognitive changes that they may have experienced, their speed of processing information means that everything is cognitively more demanding, and therefore irrespective of that rest and that recuperation, they may have that level of cognitive fatigue that just makes it that much more difficult to kind of, you know, get focused on a piece of work, to see their school day through to the end, and emotional as well, the impact of all the emotional impact of everything that's happened for them and everything that's changed. And children may get into this kind of roller coaster ride with fatigue, where they find that on some days when things are going well and they feel they've got quite a lot of energy, and the fatigue's not too bad, that they can get quite a lot done, and they want to engage in lots of things, and they want to go out and they want to see friends, and they want to do go and play football or tennis or whatever it might be. But then they find that then the next day they may have an impact of that level of activity that they've had the day before, or then on another day they just can't do anything, and the impact on them emotionally of that as well. You know, I can do this one day, but the next day I just can't, and I can't see why that's the case. So fatigue can interfere a great deal with participation, so the impact that it can have on school, so being able to get to school on time or being able to see that whole day through, the impact that it might have on being able to engage in those kind of social activities and hobbies that they might have done previously. They may find that they can do a full day at school, but then they just can't get to that kind of activity that they would normally have previously done after school. So it can result in more challenging behaviour and changes in emotions for children as well, because they're having to, you know, their tolerance levels in terms of managing things is lower because that fatigue is high. Next slide, please. So how can we help with fatigue? Well, it's really important to pace activities. So one of the things is kind of thinking about how do we manage that level of activity each day to ensure that we're not getting into this kind of those days when we're doing too much and then finding that the next day that there's a real kind of dip in those levels, and that can be really hard to manage and to find, and it can take a while to get that pacing right. And a lot of that as well is about working with schools and finding that way in which children and young people can manage that. It's important that young people also get that opportunity to do those activities as well that they might want to do, so balancing those activities that they're doing and engaging with at school to ensure that they also have that opportunity and the pacing to be able to do things at the weekend as well. So taking that graded approach to activity, kind of looking at that baseline and kind of building things up gradually when we can see what a young person can manage and tolerate. Making sure that those regular rests and breaks are there and that they're really crucial, so both in terms of that home environment but also within the school setting. and giving support in finding things that are relaxing and calming for a young person's brain. So, you know, finding those activities that bring those levels of function down so that they've got those periods of rest and recuperation throughout the day. And an idea that came up fairly recently that was mentioned was around kind of almost colour coding activities. Kind of, these are activities that use up a lot of energy, these are activities that are kind of okay, and these are activities that are really restful and recuperating, and kind of getting that balance of those different activities during the day. Okay, next slide, please. So one of the other biggest factors for some young people, and we know a proportion of children post-encephalitis, post-ABI may experience ongoing seizures. And I think this is an area which we find for young people and families is incredibly challenging, as they're managing kind of adapting to life with seizures, and also managing, trying to, you know, in that period where they might be trying to get that seizure control. So they may find that there are periods where their seizure control is very good, and other times when they're experiencing more frequent seizures. Medication may be having an impact on them in terms of their cognition. Maybe impacting on their sleep or their behaviour, and obviously there's a balance there in terms of what the medication is doing to control the seizures, and managing those side effects that there may be. And obviously there's a huge amount of anxiety potentially for young people in this kind of position where they're suddenly experiencing seizures that they haven't done before, but also not just for the young person, but the family and their friends and the school as well. And so being able to support and the family, the young person and the school to understand the seizures, to understand what happens when that occurs, and is really important. You know, you've got those ideas around the factors around maintaining safety for that young person, but also community access. So for some young people, there's a huge change in kind of their life from before to after ABI, if they're experiencing frequent seizures, because it may be stopping them from going out and doing some of those things that they previously would do, or maybe the levels of anxiety for them are stopping them from feeling able to go out and do those things in the same way. And so having that awareness and understanding for that young person and family, and trying to find supportive activities for them that will enable them to get out and do some of those activities that they're struggling to do. And one of the biggest factors that's really hard as well for a young person is that fluctuating nature of seizures. So at those points where actually their seizure control is very good, they may find they can get back to some of those things that they previously did, and then suddenly they have a period where actually that's much more difficult again. So that can be really hard for young people and families to manage. Obviously the impact can be on sleep, so for those young people who may be experiencing nocturnal seizures, that may be impacting on sleep, and that then may be impacting on their ability to get up and get to school on time in the morning, so needing that adaptation to the start of the school day in order to account for that. And then the impact of those seizures on cognition, so attention, processing speed, memory. So young people may be experiencing those difficulties as a result of their ABI, but also the impact of seizures on top of that may have an exacerbation of some of those difficulties. Next slide, please. Okay, so just to kind of put some of these things in context, I'm just going to introduce a case example. So this is an example of a young person that we might see post-encephalitis. So we're going to introduce Katie. who's a young person who was 9 years old when she developed encephalitis, had quite a long stay in hospital, and post encephalitis had an acquired brain injury with ongoing seizures. And Katie's early challenges were around significant changes in her physical and cognitive ability, high levels of fatigue, seizures that were impacting on social interactions and community access, so being able to get back to some of those activities that she may have done before, and being able to kind of go out and see friends and go and visit some of those places, some of those things around being able to kind of make sure that she was safe and those things were supervised due to the seizures that she was experiencing. She also presented with changes in personality and behaviour, so that was something that was different for both her family and her friends to kind of adapt to, and obviously had that impact on family dynamics with siblings and wider family members as well, in terms of adapting to those changes, and just the emotional impact of that sudden admission to hospital and long stay in hospital. So that's introducing Katie, and we'll kind of go on to speak a little bit more about Katie later on in the talk. Next slide, please. So I'm now going to pass on to my colleague Emily Bennett, who's going to talk a bit more about that return to school.
Hi, so I'm going to talk about something that many children and their parents report to being one of the most challenging areas after ABI, and that's returning to education. So I guess the important thing is to ask why is this so challenging? Because most children with encephalitis or another ABI will return to the school that they went to previously, but because of their brain injury, many will be going back with different or acquired needs. So what's particularly challenging about this is that many children and young people make good physical recoveries early on, and they often go back to school looking much as they did before. This can make it much harder for teachers and peers to realise the impact of their brain injury. And it's the reason that brain injuries are often called hidden disabilities. This can then be made worse by the fact that the acquired difficulties, as we mentioned, can often impact on each other, meaning that there can be a bit of a cumulative effect. And along with the impact of fatigue, as Emily's just talked about, this can lead to a fluctuating and unpredictable presentation. So getting used to this new normal, as many families will refer to it, is difficult, therefore, not only for the child and their family, but also for their friends at school and their teachers as well. Another major challenge that's experienced by many families is related to the unresponsiveness of the funding and support systems for children who do have additional needs at school. We've all heard in the news about the shortfalls in funding for special educational needs, but there's also difficulties in relation to the lengthy timeframes for a lot of these systems. And these are unhelpful really when it comes to sudden changes in needs that we might see after ABI. So, for example, to get a education, health and care plan, an EHCP, takes 20 weeks. So if you think about that in the context of an ABI where a child's had a sudden change in needs, then actually they may already at that point be back at school and struggling with the difficulties they're facing before there's any funding and kind of support put in place because of that EHCP. Further to those challenges with the systems, teaching staff also report quite often to feeling quite ill prepared to support a child in returning to school with an ABI. This is because, for a lot of reasons really, the ABI as a sort of condition is not mentioned within the Special Educational Needs Code of Practice, and nor is it addressed in initial teacher training or even in the training that all SENCOs, so the Special Educational Needs Coordinators in schools, complete. Furthermore, there's only a handful of pathways that are designed to support children and young people to return to and remain in education after a brain injury. And that means that schools frequently feel quite underprepared to support a young person, and they don't always know what's expected of them. This then isn't helped by ongoing failings that we know happen between health and education settings and other agencies. And there are a lot of common misconceptions about ABI, as was mentioned earlier, that are held by many people, and that does include teachers as well. So what this can mean is that when there are changes in behaviour, emotions, or perhaps social or cognitive changes, those people who are working with the child may not understand that that's related to the ABI and instead misinterpret this. So sometimes this can lead to assumptions that a young person is perhaps being challenging in their behaviour in some way, or that they're not paying attention or making effort in their learning, rather than the recognition that this is actually because they're struggling because of their acquired brain injury. Next slide, please. So, you know, despite all of those challenges, schools really are a crucial part of a child's rehab after ABI. The return to school is really, really important because it immerses a child in a natural and experience-rich environment, and that's a great environment for rehab. So because of this, schools have a really crucial role in helping children with ABIs to relearn skills, but also to compensate for the acquired difficulties that they might be experiencing. And this isn't just from an academic perspective, but also from those social and emotional perspectives as well. And we estimate that around 70% of a child's rehab is happening within schools. So it really is important that schools feel confident in understanding ABI and also in meeting a child or young person's new needs. Next slide, please. So having started with a lot of the challenges that we might face, we also want to talk about the positive things that can be done to make the transition back to education better for everyone involved. I think that feels really important, doesn't it? Because it upskills people to feel that they do understand ABI and that they can do something to help. So firstly, when we're thinking about supporting a return to education, there are a number of core principles which can help to ensure a young person has a successful and well-supported return. So in particular, the return should be a collaborative effort. It should be well planned and centred on the young person and their family. It's really, really crucial that there's good communication with everyone involved. And it's also helpful if planning considers things like participation and inclusion as core components, so that we can help the child to re-immerse themselves in that school environment effectively. We know that having clear pathways for supporting the return can be hugely beneficial, but these are really sparse still in the UK. So where they do exist, we know that transitions are generally better planned and smoother, and families report to feeling less anxious about the process. Kind of looking at this on a national level, there have been recommendations made in the Time for Change report by the all-party parliamentary group for acquired brain injury, which recommends that return to education pathways are established. And on the back of this, the National ABI and Learning and Education Syndicate, or ENABLES, are about to publish best practice guidance for schools and professionals to help them to facilitate that effective return to school. There's links to those documents and other resources that we'll show at the end for those who are interested. We also have a pathway in Nottinghamshire where Emily and I work, which is called the Sam White pathway, and there's lots of extra information in there for any teachers who might be listening or others who might be interested to have a look at kind of how a local pathway can work as well. Next slide, please. So now we want to think a bit about how we can encourage and help schools to offer effective support and rehab for children when they are back in school. So within the Nottinghamshire ABI pathway that I mentioned, we promote some key principles for doing this, and we try to suggest that this is a cyclical process that involves communication, education, adaptation and evolution of kind of support. So if we think about those kind of one by one, we'll move to the next slide, please, and I'll talk a bit about communication. Thank you. So this is really important when it comes to a newly acquired ABI, because often problems emerge when there's a breakdown or a lack of communication between the different agencies. Communication can be massively assisted by the allocation of a key worker who can act as the main point of contact for the child, their parents, the school staff and for other professionals as well. And what this ensures is that that key worker is able to collect all the information about the child and their needs and share that effectively, so that any problems that arise will be quickly managed and sort of addressed as soon as possible. The key worker can also play a really important role in ensuring communications from the healthcare teams and other professionals who work with the child actually get circulated properly within the school environment. So it's really important that everybody who works with the child knows about their needs, and that's everyone from the head teacher to the lunchtime supervisors and other people who might be involved, because they all need to be aware of the needs the child might have and how they can best be supported. Another thing about communication that's important to mention is thinking about keeping the child at the centre of all of that and asking them what they want and need, and how things are going for them, kind of with the return to school process and then going forwards from there. So in a review of goals at the Cambridge Centre for Paediatric Neuro Rehab, most of the goals that were selected by the young people themselves were about participation, particularly with regard to school, their needs being understood within school, feeling part of things and being with their friends. So if we're not communicating effectively with young people and then sharing their views successfully, we're likely to be getting that support wrong in some way. So it's a really important part of what we can do. Next slide, please. As mentioned earlier, when we think about sort of educating people about acquired brain injury, most teachers have little, if any, training about ABI, and this can mean that young people's needs are poorly understood or misinterpreted. It's really crucial that teachers do receive training about brain injury so that they can use their already kind of broad skill set to appropriately teach and support a child from the cognitive, behavioural and emotional perspectives that they may need support. Training will often be offered to teachers by the hospital team and by local brain injury specialists or coordinators from the Child Brain Injury Trust or the Children's Trust. And there's also lots of really good training out there. So there's additional training provided for free for schools by the Child Brain Injury Trust and the Eden Dora Trust. And there's a new schools award that is helping schools to become more ABI aware in their training and policies that's worth kind of considering as well. Next slide, please. So when we think about adapting things within schools for children after ABI, this can happen on a number of levels. So on one level, it might involve thinking about teaching strategies so that we can ensure a young person can access the content of the lesson, or ensure that they have regular brain breaks, for example, to help them manage their fatigue. On a curriculum level, adaptations might include changes to the length of the day for the young person, particularly early after injury, or perhaps it might be to the number of subjects that they're taking, if they're likely to need more time to rest, to have those brain breaks, or perhaps to have opportunities for repetition and kind of relearning and overlearning of subjects as well. So adaptations often also include special considerations for exams and assessments, and schools should be encouraged to put those allowances, such as extra time or breaks or access to a scribe or a reader, in place as soon as they can, and that should be for all assessments, not just exams. So any sort of in-class assessments should have those things in place as well. And then finally, thinking on a systems level within school, adaptations to behaviour management strategies can be particularly important for helping schools to support a young person after an ABI. This can make a particular difference when a young person perhaps has difficulties with executive function, so things such as impulsivity or disinhibition, because these things can be really challenging for teachers to kind of recognise and know how to respond to within the existing policies that there may be within school. And finally, if we move on to evolve, please. Thank you. It's really important for schools to understand that support needs to evolve over time. So ABIs are dynamic conditions. When a child first goes back to school and they're in their early stages of recovery, they may well have significant needs that might decrease gradually over time. But it's also possible that the child's needs will increase as their brain develops, or as the kind of demands of the school environment increase and they perhaps don't continue to keep up with the trajectory they were on. So in this sense, it's really important for people who are working with the young person to hold that ABI and its impact in mind, and to do that kind of going forwards throughout their time in school. But, you know, within thinking about that, we don't want that to be at the cost of remembering the child at the centre of that as well. So we're trying to also think about that child or young person's identity, their unique needs, and how we can kind of incorporate all of those things into the best opportunities for them within education as we can. And what we like to think about is then that cycle that I've just talked about becomes a repeating cycle. So they would, after thinking about evolution, we would go back to thinking, do we need to communicate something about this? Do we need to educate people? How do we make adaptations, and do we need to evolve that support going forwards? Next slide, please. So just really quickly to go back to the case example we spoke about, Katie. So in terms of the support that she received, she was placed on the local pathway within Nottinghamshire, and that meant that all the relevant agencies were informed. A link educational psychologist was assigned to support her by the local EP service, and she was placed on the ABI review list, which meant that she would never get lost in that system. She was always going to be kind of checked on, and the ABI wouldn't be forgotten kind of as she progressed through school. All those teams managed to have input from the first discharge planning meetings in the hospital, and with the home education team and so on and so forth, and moving forwards back to when school started taking over those meetings as well. The planning for her return to school started very early on as well, and we had regular meetings to make sure that kind of everybody knew what their role was, what their responsibilities were, and whether any planning and preparation needed to be in place. Initially that was organised by the hospital team, and after discharge by the school and the educational psychologist. And then finally, school made adaptations to her timetable and to her school day, making sure that she had the chance to have that phased return where she gradually increased her time in school, taking account for her fatigue, for those seizures and kind of everything else that was going on for her. And there were also changes made to the behaviour management strategies that were used within school, just to make sure that that support really had that evolutionary sort of approach, but also was individualised to Katie's needs. Next slide, please. So in summary, early discharge from hospital and return to school can be really, really challenging for the child and their family and also the surrounding system. But actually what we do know is that when we have a proactive, coordinated and child-centred approach, this can really help to frame things in a more positive light and to ensure that everybody involved kind of knows their roles, knows what they can expect, and hopefully feels less anxious about that process. On the last slide, we've got a number of key organisations, pathways and sources of information. And thank you very much for your time and for listening today.
Thank you very much, both the Emily. Absolutely really insightful talk, and really sort of built off from Santosh's talk about the difficulties children who have ABI have, you know, post-discharge. And I think there's some really good practical advice there on how they can be helped, both by in the family setting, you know, and their friends, and also in the school. So I think it's been an absolutely wonderful talk. And I think your slide, for me, in working with children who've had acquired brain injuries for like 15 years, your slide of that iceberg of the hidden disability totally encapsulated it, you know, and I think it was so powerful. And I think, you know, I think people in Nottingham are very lucky to have that, you know, that pathway. And I suppose it's quite alarming to see that it wasn't probably universal, you know, in 2021 for me. So absolutely, thank you so much, both the Emilys, really fantastic. So we're going to move on to a comfort break now. And what I'm going to suggest is that we return about 20 past, have a little more than 5 minutes. I like to round things up so you can go off and get a cup of tea and do what you need to do. But if people obviously want to stay on, we've put on some slides for this comfort break and the next one, just about some of the families that we've helped at the Eden Dora Encephalitis charity, and sort of put things into context. So we'll hopefully return about 11:20, and please continue to send your questions through for the question and answer session. And I hope you've enjoyed everything so far. Thank you. So welcome back, everyone. I hope you've been suitably watered and managed to stretch your legs. So I'm pleased now to introduce our third speaker this morning, and we've got the wonderful privilege of hearing, and I've been dying to hear her for quite a few years, Dr. Heather Elphick, who's a consultant in paediatric respiratory and sleep medicine at Sheffield Children's Hospital. And we've seen from the earlier talks the importance and how sleep is one of the factors and the impacts of sleep on people with ABI. So Heather's going to talk to us particularly about encephalitis and sleep and the importance of it for an encephalitis and acquired brain injury. So I'll have pleasure to hand over to Heather now. Thank you.
Thanks very much, Julianne, and thank you for asking me to speak today. I'm really pleased to be able to speak to you about the role of sleep in children that have had encephalitis. As all of the previous speakers have mentioned, it's well recognised that children that have had encephalitis and ABI do have an awful lot of sleep problems following the injury and, you know, for a long time afterwards. But a lot of the time this isn't formally reported or investigated and treated, and so I wanted to just give a little bit of an overview about the causes of sleep problems and what we can try to do about them going forwards. So next slide, please. So I'm going to tell you a little bit about the science of sleep and what we do when we're monitoring children's sleep patterns before I go on to talk about the relationship between encephalitis and other forms of ABI and sleep difficulties, and to just have a think about when we should be looking at sleep issues and when we should be assessing and trying to address them, and also just to highlight that there's still a lot that we don't know about the relationship between ABI and sleep, and there's a lot of future research that that can be done. Next slide, please. So why is sleep important? We all know, are very aware of the fact that when we've had a bad night's sleep, we can feel really quite rubbish the next day. It has an impact on our ability to function. It can make us feel very grumpy, snappy, and for those of us that have had long-term problems with sleep deprivation, you know, it can really very adversely affect people's mental and physical health and emotional well-being, and has knock-on effects for those you know, for others around us, and has a much wider impact as well. And this is also the case for children. So in our service we see lots of children that have very severe and chronic sleep deprivation, and the impact that it can have on the child itself is quite you know, far-reaching in terms of their health and also their ability to function in school and their education, has an impact for the family system around them, so often causes lots of stress and health difficulties for their parents and siblings, and of course that then has a wider impact on the NHS, lots of prescriptions of drugs for children and for parents who become depressed due to the long-term sleep deprivation, and issues with productivity, and so it goes on. And for anybody that's interested in the sleep and you know, the impacts of sleep and why we sleep and how, you know, the importance of it, I would recommend this book by Matthew Walker, who's an American neuroscientist. It's a really interesting read. Next slide, please. So in the Sheffield Children's, we have quite a large sleep service. We look at physiological and behavioural sleep problems. We have a sleep unit where we monitor children's sleep overnight using a multi-channel recording system called polysomnography. And what we're looking at is the different stages of children's sleep and the different disorders that can affect those different stages. So we look at the brain activity and we diagnose the different stages of sleep really according to pattern recognition. So this slide just shows you the different stages of sleep that we go through, from being awake through to drowsy, stage 1 sleep being light sleep, and stage 3 sleep being that deep sleep that we recognise by these large delta waves in the EEG. Next slide, please. So those were the phases of non-REM sleep, and then there's one further phase of sleep called REM sleep, which we recognise by the fact that there are rapid eye movements in the patient whilst they're in REM sleep, and then there are some other features that we can also pick out from the EEG recordings as well. And it's important that we have both non-REM sleep and REM sleep on a normal night's sleep. Next slide, please. And we plot the different phases of sleep that that the child goes through when we're monitoring them in what we call the hypnogram, which is a pattern of the different sleep stages through the course of the night. So this is a hypnogram of a typical adult who's had about just between 7 and 8 hours of sleep, and you can see that they go from awake through to deep sleep through the course of about half an hour, and that most of the first third of the night is spent in a deep sleep, and then we cycle through the lighter stages of sleep and REM sleep in the second 2/3 of the night. And I'll explain the importance of this in the next couple of slides. So next slide, please. So what happens to our body when we fall asleep? Well, when we first go into non-REM sleep, our body becomes relaxed, our muscle tone decreases, we get more floppy, and our other physiological responses decrease slightly. So we have a slight drop in body temperature and breathing rate, heart rate and blood pressure. And then when we go into REM sleep, then these effects are even more exaggerated. So our muscle tone becomes very low, almost to the point of paralysis of the muscles. And there's a further drop in the breathing and cardiac responses, but we also have what we call the phasic changes of REM sleep, where we can see the rapid eye movements, and there's muscle twitching and irregularities in the breathing and the heart rate. REM sleep is when we dream, and it's also important for us when we're diagnosing problems such as sleep apnea. They're much more common in REM sleep. Next slide, please. And more importantly, for the context that we're talking about, what happens in our brain when we sleep. Actually, our brains are very active when we're asleep, which is why it's so important that we try to have a good night's sleep. And it's important that we have the right proportions of non-REM and REM sleep. So when we're awake, there's lots of sensory input going into our brain from what we're seeing, what we're hearing, and so on. And when we go to sleep, all of that information is being sorted out and processed and stored in our long-term memory. And during non-REM sleep, it tends to be the more factual information that's stored and that's processed and stored. And then during our REM sleep, it tends to be the more emotional information and processing of our cognitive functions that's happening. So very important that we get both REM sleep and non-REM sleep in the right proportions and enough of each in order to process what we're learning. And so you can start to see the importance of when children have sleep deprivation, that this can have an impact on their learning and their memory. Next slide, please. This is quite a nice table from the Sleep Foundation, which sets out how many hours of sleep are recommended for the different age groups during childhood. So as you would expect, more sleep is needed during the period of the most intense brain development in the first year of life, and then through to 8 to 10 hours of sleep needed for teenagers, which is slightly more than what we need as an adult. Next slide, please. And this is just to illustrate the circadian rhythm. So sleep is obviously part of our 24-hour circadian rhythm. It happens naturally every day, and it's regulated by a hormone called melatonin, which is produced in the pineal gland of the brain, which is secreted in response to light and dark. So as it goes dark in the evening, our melatonin secretion increases, makes us feel sleepy and helps us to sleep overnight. And then in the morning, when there's daylight, that inhibits the secretion of melatonin, so we stop secreting the melatonin and we wake up and we remain wakeful during the day in an ideal situation. Next slide, please. So just a little bit about what happens when sleep goes wrong. We see lots of children that have difficulty sleeping, and once we've ruled out any physiological sleep disorder, we still have a lot of children that we see who have behavioural or habitual sleep problems that we need to try to correct. And a lot of the time this is because they're partially awakening at night. And you can see that, so these are hypnograms of examples of people who are waking at night, and you can see all of the vertical lines on here are partial awakenings. And if we wake up and go back to sleep again, then it's just a vertical line. We go straight back to sleep again. But sometimes these partial awakenings can lead to full awakenings, and this is when children wake up in the night. Next slide, please. So as I say, for people that have good sleep habits and sleep well, we're often not aware of these partial awakenings that are happening overnight. We just simply turn over and go back to sleep. But it's important to recognise for children who wake up in the night that often the reason for the full awakening in the night is that they can't self-settle back to sleep after they've had a partial awakening. So what we really focus on is helping children to self-settle, because if they can self-settle at the beginning of the night without a parent present, then if they wake up in the night, then they learn to re-self-settle, and then these partial awakenings don't become full awakenings, they just remain partial awakenings, and they can settle themselves back to sleep. So this is really the key to the children that have habitual awakenings overnight, and is really, what we really try to concentrate on in a lot of our work. Next slide, please. So coming on to the association between sleep problems and acquired brain injury. So as I said before, there really isn't very much in the literature that's formally recorded and reported the problems with sleep. But this was quite a useful review paper that I found, that talking particularly about traumatic brain injury and reporting that sleep-wake disturbances occur in between 30 and 70% of individuals, depending on which paper you read, and they reported a range of articles, and that these problems can remain up to 3 years post-injury. In our experience, they can remain for a lot longer than that if they're not addressed. And also, one of their conclusions was that these sleep-wake disturbances can exacerbate really the disruption to exacerbate the other complications of the brain injury. So the sleep disruption can exacerbate those other complications, including the memory and cognitive problems. Which relates back to the the slide I showed you, talking about why it's important for us to have non-REM and REM sleep for processing our memory and cognitive function. But it can also contribute to the ongoing chronic pain and psychological distress that the children experience after brain injury as well. There are reports both of insomnia, where children have difficulty sleeping or can't get to sleep, and also children that actually have excessive sleepiness following their brain injury. Next slide, please. So this was another recent article published last year, which is interesting and outlines in more detail some of the sleep problems that can occur in children following brain injury. So they looked at 78 children, range of ages, as you can see, and also a range of underlying causes for their acquired brain injury. So obviously with the Eden Dora Trust, we're interested in children with encephalitis, and there were 10 children there with infectious or inflammatory causes for their acquired brain injury, but there are also other children with trauma, stroke and other causes there as well. And they separated out the different sleep difficulties that were reported according to the underlying cause. So they evaluated the sleep problems 1 to 3 months after the child had been discharged home from hospital, using what's called the Sleep Disturbances Scale for Children, which is a questionnaire that parents fill in on behalf of their child. Next slide, please. So I've just put together some tables that highlight their main results. So they reported that there are sleep problems identified in 56% of the patients. As you can see, I've highlighted there in bold, the most commonly reported sleep problem was insomnia. There were also some sleep apnea, quite a high proportion of parasomnia, so sleepwalking, night terrors, also nightmares, and nearly 20% of those children also reported daytime sleepiness. Some of these were reported in more than one child, which is why the numbers don't add up to 100%. So next slide, please. So looking in more detail at those children that reported insomnia following their brain injury. So you can see there again, I've highlighted in bold, so the 47% of children that had some insomnia, 33% reported severe insomnia, and then if you look along at the underlying causes of the insomnia, you can see that for the children that had infectious or inflammatory causes for their brain injury, so children with encephalitis falling into this group, this was by far the most prevalent group in which children had insomnia following their brain injury. Next slide, please. So just a little bit to say about hypersomnia after brain injury as well. So these are the children that feel much more sleepy after their brain injury, and this is much more common in the children that have had traumatic brain injury as opposed to encephalitis, and this is reported to be related more to those that have a more severe injury, so children that have been in coma for more than 24 hours or have required neurosurgery or have had an associated skull fracture, and it seems to in many cases be associated with the injury to the particular part of the brain that's associated with control of sleepiness, so that the hypothalamus and specific injury to that area of the brain. And these children seem to develop a phenotype which resembles narcolepsy. So narcolepsy is a condition which is manifest by uncontrollable sleep episodes during the day and an excessive need for sleep, but also quite severe sleep fragmentation during the night. And in narcolepsy, often the child has low levels of a neurotransmitter called orexin, which is secreted from specific cells and regulates our sleep-wake cycle. And in the children that present with hypersomnia following brain injury, they have a very similar phenotype, and so they're sometimes called secondary, or it's one of the causes of secondary narcolepsy, and so we would treat these children the same way that we would treat children with narcolepsy. Next slide, please. But coming back to the more common scenario, which is where children have insomnia or difficulty getting to sleep, I'm sorry that some of the words have sort of not quite come out very well here in the circles, but I think you can still see what I was trying to say. So these are some of the factors that lead to the sleep problems after acquired brain injury, and you know, there are many factors that play into this. But interestingly, the severity of the illness is not reported as being one of the main factors that predisposes to sleep disturbance. So you can still get significant sleep disturbance even if you had a relatively mild encephalitic illness. So there are many factors. So starting with the environmental. So if you imagine a child that's been in hospital for a prolonged period, hospitals are not places that are conducive to good sleep. There's lots of noise going on. There are lots of alarms. The child might have had drips that needed to be seen to, medications that were given at times that were not necessarily conducive to sleep because of the pressures on the ward, and lots going on, and all of this has an impact on the sleep pattern. the cognitive fatigue that Emily mentioned earlier, and some of the other emotional factors that are sort of associated with the adjustment to the child's new lifestyle, really, with following the brain injury, can lead to emotional problems and anxiety, and these sorts of factors can kind of impair the child's ability to get to sleep, and that's something that we work on. And Emily also, mentioned that's something that they really focus on as well. Other factors, the child might have had previous comorbidity such as autism, ADHD, other neurodevelopmental problems that can that have a very high incidence of sleep disturbance. The child's own personality and the way that the family has responded to the illness can play into this as well. As I said, fears and anxieties, and other physical factors, so the seizures and the pain that children develop and suffer following injury can have an impact on their ability to get to sleep as well. I've mentioned the adjustment and emotional factors. Medications that are used, particularly anticonvulsant medications, can lead to alterations in the sleep stages, which can lead to fragmentation and poor quality sleep. And the melatonin that should be secreted in the regular 24-hour cycle can be altered and very disrupted by the stay in hospital. So many factors contributing to the sleep disturbance. Next slide, please. And the sleep disturbance then has an impact on many of the other factors associated with the child's recovery. So as you know, has already been discussed in previous talks, it can impair many of the cognitive problems that the child already has following the brain injury, and it can exacerbate those problems. And the fact that the child isn't sleeping at night can just make it very much more difficult for the family to cope, can affect the child's attention and concentration and their memory and ability to process and to progress at school, as well as their mood and emotional regulation. Next slide, please. So again, some of the review articles that have looked at outcomes in relation to sleep disruption, either poor sleep or good sleep following acquired brain injury. You can see here that poor outcomes are generally listed in response to sleep disruption for up to a year, and this can impact on their neurological sequelae, including depression, anxiety, and so on, for up to 12 months after the injury. Whereas if the child has a good consolidated sleep-wake pattern, it's been shown that they do have a shorter length of hospitalisation, lower disability rating scores, and a more rapid resolution of post-traumatic amnesia. Next slide, please. So if you remember back to Santosh's talk, he talked about synapses and how the importance of the regeneration of the synapses following brain injury, and that actually because children's brains are rapidly developing, this can actually lead to worse outcomes. And there is some evidence that improving sleep can actually improve the recovery of the synapses following the brain injury. So the synapses are where the two neurons meet and pass the information from one to another, and this is done by releasing substances into the gap between the neurons where they pick up the signal. One picks up the signal from the other. And following a brain injury, it's said that there's a metabolic storm, so lots of factors are released into the synapse, including inflammatory substances and neurotransmitters. And there is some evidence to show that improving sleep can actually clear away these factors more quickly and leads to more rapid recovery of the synapse. The clearing of the synapses leads to more rapid recovery of the neurons. So another underlying reason why it's really important to improve sleep if we can. Next slide, please. Okay, so coming to when should we be assessing for sleep problems in a child that's been admitted to hospital with encephalitis or another cause of brain injury? So we talked about neurorehabilitation and its importance in helping children to start to recover in all the different multidisciplinary aspects. So the physical, cognitive, emotional and behavioural rehabilitation are all equally important and all interact with each other. So if there's a difficulty in one area, then it can lead to a slower recovery in the other areas. And there are lots of factors that need to be addressed in terms of the child's rehabilitation, both in hospital and following discharge. But one aspect that often is overlooked in many cases is that there's a sleep assessment and support of their sleep can help for the child to recover in all of these other areas as well. And I hope that what I've outlined in my previous slides helps to convince you that this is the case. And I think it's important for us to consider that a sleep assessment and support for sleep should be started almost straight away and to be part of the integrated multidisciplinary team around the child alongside the other therapies really from the outset, so that we can try to improve the sleep as quickly as we can to help with the child's overall recovery. Next slide, please. So how do we assess sleep problems? So coming back to the beginning of my talk, when I talked about the sleep unit, we monitor children overnight with polysomnography if we're looking for physiological sleep problems, and this involves an overnight stay in hospital. There are other ways that we assess sleep as well, though. So we use ActiWatches, which look at sleep-wake patterns, and we use these for 1 to 2 week periods so that we can look at a child's sleep-wake pattern over the course of that period of time, so that we can look at how fragmented their sleep is at night, and how much they may or may not be falling asleep during the day, and their overall sleep quantity. And then we also have an amazing team of sleep nurses and sleep practitioners who assess children in terms of their sleep behaviour and their sleep patterns and their sleep routines, and they do a very full and detailed assessment of exactly what's going on around the child's sleep onset in the evening, and they give some advice as to how that can be improved. Next slide, please. So the strategies for treatment for sleep problems, both non-pharmacological and pharmacological, we try to concentrate on non-pharmacological help wherever we can, if possible. And so this is where the sleep nurses and practitioners come in, and they talk to the families about basic sleep education, and they make a one-to-one individualized plan with the family. And so these, for families that are being followed up as outpatients, they have follow-up telephone support from the sleep practitioner, and usually they undergo a course of treatment which lasts around, on average, 6 to 7 weeks. Next slide, please. And these are the sorts of things that they will recommend. So the key really is to concentrate on that self-settling at bedtime and to develop a consistent bedtime routine that involve, and they give practical advice such as helping with removal of screens, which has obviously become quite a big issue with children at bedtime in recent years, helping them to self-settle, and talking about helping the parents to reward good nighttime behaviour. Next slide, please. So this is an example of the sort of sleep plan that they would come up with. So this is for a patient who we've named Danny, whose bedtime is planned to be at 9:30. And so they start the bedtime routine at 8:30. So it's all about what's happening in the hour leading up to the child hopefully falling to sleep. So they start with switching off technology, dimming the lights, making it a nice, cozy, darkened environment, and talking about the sorts of activities that are conducive to sleep. So they tend to be the type of activities that involve hand-eye coordination, so that the child is concentrating but not overstimulated. So things like colouring and doing Lego and jigsaws are ideal activities. And they'll recommend supper from a sleepy foods list that they give to the families, and these sleepy foods tend to contain a little bit of melatonin, which helps to boost the child's own production of melatonin. Then they usually recommend a warm bath if that's not too overstimulating, not to return downstairs at that point, but to go straight into the bedroom after doing teeth and toilet, and then to have a limited amount of reading time, followed by a consistent and quite boring little phrase that the parent will say every night, which is a signal to the child it's now time to go to sleep. So this is the example of the sleep plan, and what the practitioners do is that they support the parents to help the child to put this into place at home. Next slide, please. And we've done some research looking at this approach, and this particular study was looking at children with ADHD, where they had the sleep practitioners intervention, and amazingly they managed to result in the children gaining an extra 2.4 hours of sleep a night, which is just unbelievable amount of extra sleep, and even at 12 months follow-up, that had dipped a little bit to 1.8 hours, but still a very significant amount of extra sleep for these children following the sleep practitioner's intervention. Next slide, please. This is a busy slide, I'm sorry about that. It's just to illustrate what we call the Sheffield Children's Sleeping Well pathway. So we've made a lot of progress in implementing the sleep practitioner's pathway in Sheffield, both within the Children's Trust and also within the community, so that our overall aim is that children can and their families can access the right level of sleep support for them at some point within the pathway. Next slide, please. And then just briefly for the medics that are attending, some of the pharmacological strategies that we use as well for sleep problems. So obviously if we do find an underlying physiological sleep disorder such as sleep apnea, then we will treat that specifically. But if the non-pharmacological, so the sleep practitioner approach has not helped or not sufficiently helped, then we do use melatonin in some cases. We in children with brain injury, we specifically recommend that you avoid benzodiazepines because that can have an effect on the child's cognitive function during the day, and they also suppress slow wave sleep and therefore can suppress brain recovery. And then we'll use wake promoters for children with hypersomnia as needed. Next slide, please. So yeah, this was just, I won't go through this slide in detail because we're short of time now, but this is just really to highlight what we don't know yet about the relationship between encephalitis and sleep. There's an awful lot that we don't know, and that that future research hopefully will address. Next slide, please. So in summary, I hope that this has illustrated to you that sleep is really important for our physical, cognitive and social well-being, and it's especially important after brain injury, and also that improved sleep can aid recovery from brain injury. I've highlighted, I think, that sleep problems are common after encephalitis, particularly the insomnia, and that there are still a lot of unanswered questions. And I think the important messages to take away really is that it's important to be aware of potential sleep issues when a child's been admitted with a brain injury, and to intervene early. And I do think that it's important for sleep practitioners to be included in the multidisciplinary team so that they can work with the other therapists to give the child the best outcome. Thank you very much.
Thanks so much, Heather. That was absolutely fantastic, fascinating. And I know certainly from what we see at Eden Dora, and also in my practice with children with acquired brain injuries, sleep is, and sleep problems is so common, and we hear stories of families having to sort of sleep next to the child waking up 8 or 9 times a night. And also, so I seem to have lots of birds outside my window, and also the impact on the siblings who sometimes share, and it's often an area that we find is really forgotten about in that MDT, and it just really impacts. So it's been absolutely fascinating to hear, and obviously the difference it can make, and the support hopefully that families and practitioners now know that's there. So thank you so much for that. So move on to our fourth speaker, and I have the pleasure of introducing Beth Wicks. So Beth is a specialist educational consultant, and she's also got the esteemed where she is a chair of the International Paediatric Brain Injury Society. And Beth's going to talk to us about a child's world after encephalitis, and she's going to look at it from a child's perspective and also how they can be supported going forward. So without much further ado, I'll hand over to Beth. Thank you.
Thanks very much, Julianne, and thanks to the Eden Dora Trust for inviting me to speak. If we could perhaps just go straight on to the next slide. We've had some great presentations this morning regarding various aspects of things that people will encounter after encephalitis in childhood, and I'm just going to concentrate in the next half hour really on some other specific issues in terms of the way that young people view themselves and think about themselves, and the way that they interact with other people. I think it's important. I've been listening to everybody else this morning, and I think that I've been working in this field for a very long time, and initially when I was, when I first started, and then for some considerable time after that, people were aware of traumatic brain injuries, but if you actually mentioned the broader term of acquired brain injury in relation to infections such as encephalitis and other causes of acquired brain injury, then people would be quite surprised and probably didn't recognise that. So I think it's important that we all have been talking today about encephalitis being having the potential to cause acquired brain injury. I think it's also important to remember that every child is different and every child is unique. And so although we're talking about issues which may affect children after encephalitis, they're not all going to be affected by all of these issues, and that each child can be affected by any combination and any level of severity of the sort of issues that we're talking about. You do sometimes hear people say that once you've seen one acquired brain injury, you've seen one acquired brain injury. So it's important to remember how different all children are. But I also mentioned, of course, that and other people have as well, that we're talking about children here with developing brains. And so it's important first, from the issues that I'm going to consider, to think about the age and the developmental stage of the child when they were first ill. Could I have the next slide, please? So we haven't got time this morning really to consider children's neurodevelopment in any detail, but there certainly are peaks and troughs within a young person's developmental trajectory, and so they do kind of correlate to a certain extent with those 4 stages that I've put there. I mean, it's a generalization and it's quite broad, but if we think about the sort of preschool age and primary school age, but I probably should have said sort of earlier primary school, and we could perhaps lump the older primary school age children with the preteens and then adolescents. And considering the way that young people view themselves and their awareness of themselves as people, really, you obviously can see that there's a huge difference depending on the age of the child at the time of the illness or injury. And so it's important to consider that. It's also important to consider, as other people have mentioned today, that skill development at the time of the injury is most vulnerable to disruption compared with that which has developed prior to that. And as has also been mentioned, the subsequent development after the injury is unpredictable. So the effects of an acquired brain injury can provoke difficulties and changes to previous levels of ability and changes to the way that we function as people. And whether we've thought about it consciously or not, we all have an awareness of ourselves which develops during the course of our childhood and beyond. Next slide, please. So if you think about our sense of self, our sense of who we are, you can consider it really as a combination of personality and identity. I mean, we all kind of tend to characterize people in the way that we see their personality, but we perhaps don't think as consciously really about identity. And that's linked with children as well as adults really, but particularly when we're considering children now, linked with various situations. So it can be linked by the way that they see themselves in the home and the family. So they see themselves as being a son or a daughter to two parents, to one parent, to a parent and a step parent. They see themselves as being a younger sibling, an older sibling, and they see the way that they learn gradually as they grow up, the way that they kind of fit in with that situation within the home and how they fit in with their siblings, for instance. And then in school, they know where they fit within the group of young people with whom they come into contact every day. So they can identify themselves as being someone who's really good at maths because they always have been and they find that easy, but they find other things more difficult. And they know sort of how they fit within that situation, and they identify possibly with other young people who have, you know, similar, who see themselves in a similar way. And even more importantly, often leisure and sporting activities. They may see themselves as someone who's really good at football, and so they identify with the other footballers. It may be because they are playing a sport such as football, or it may be that they identify themselves as someone who supports Manchester United. So therefore they identify with the group of people a group of other young people, other children they come across who support Manchester United. And that means that they can talk about the players in the team, they can talk about the latest results in the league, they can remember those things, and they're aware of what's of what's happening. And also, of course, it's very closely linked to sort of social and peer interactions. So they identify themselves with a certain group of people, a group of people who enjoy doing certain activities, a group of young people, particularly in their teens, who dress in a certain way. And so therefore it's important, and it's increasingly important as children develop, to fit in with the groups with which they identify. And that sort of sense of self or identity really is linked with, but it's different from, self-esteem and self-confidence. So could I have the next slide, please? So self-esteem is a product of lots of different factors, and including confidence and self-image, and it is different from identity, and it is often closely linked to school performance. So I mentioned before young people who may see themselves as being good at certain things in school, be, as I said, good at maths or particularly good at science, and young people see themselves within that hierarchical structure, if you like, of the group around them, the class around them. And, you know, lots of research has shown that self-esteem is often negatively associated with acquired brain injuries. So young people who may have previously had reasonably high self-esteem may struggle with the differences that they've then acquired after their illness and injury. Next slide, please. So under normal circumstances, we often have opportunities to sorry, I think I lost the connection for a moment there. But because of loss of skills and abilities that children sometimes have, it can provoke changes that reduce their opportunities to confirm those self-concepts. So for instance, if you are affected physically after acquired brain injury and you identified as somebody who was good at football, then you are unable to actually join in with those sort of activities anymore, and so reinforce those self-concepts, which can negatively affect the way that you see yourself. And it can be quite difficult to then review and adjust the way that you do see yourself. And if you can't cope with that, what you can see is a significant loss or change, it can have a profound effect on your emotional state and your self-image. So it's a sort of, you know, it's a two-way thing, really. Okay, can you have the next slide, please? So as well as the way that we see ourselves and the way that then we interact with and with others, the slide here talks about common cognitive and communication problems. Communication problems after acquired brain injury are often rooted in those cognitive difficulties. So, for instance, if you have difficulties with concentration and attention, as people have mentioned before, that can really affect your ability to carry on a conversation and to communicate with others. It can also affect the way that you're communicating in other ways as well, virtually, as we're doing at the moment, or in writing. If you have memory deficits, again, it can affect the way that you communicate with other people, because you can't remember possibly what you've just said. You can't remember what the other person has said once you start to answer them, and you can't possibly you can't remember a previous conversation that you had the day before. Somebody else earlier on as well mentioned problems with organisation, and if when you're thinking about what you're going to say, be it spoken or written, then you're automatically and often unconsciously, but sometimes partially consciously, organising what you're going to say and how you're going to communicate. I remember working with a young person some while ago who, when she went back to school, she was in her teens. She was studying for A-levels at the time, and she was producing work which was incredibly lengthy, and she couldn't understand why, for instance, she didn't get high grades for what she was producing, because she said, I put so much work into it and I've done so much. But the problem was that it was too much. It was completely disorganized, and so it was a huge amount of effort for not much reward, which was extremely frustrating from her point of view. As I think other people have also mentioned, young people can have then difficulties with understanding jokes or sarcasm, with understanding metaphors or any sort of pragmatic language. Again, you can imagine how this can affect a young person with their peers. If they don't get the jokes, then they can become a butt of jokes themselves. If they don't understand when someone's being sarcastic and takes it and take things literally, then again, it can make them extremely vulnerable, and other young people can find that a source of amusement. And then if young people have difficulty understanding non-verbal communication, again, if they do have problems with the organisation of their communication, or they're not understanding those jokes or those sarcastic comments, it might be that other people with whom they're talking might raise their eyebrows or turn away or pull a face, in which case most people would pick up that cue and realise that what they were saying was perhaps not appropriate, or that they had misunderstood. But if you don't understand that non-verbal communication, then again, it can cause you huge amounts of difficulty socially. And also, if you have problems with understanding any sort of imaginative language, young people after acquired brain injury can be very concrete thinkers. So again, it can create issues in terms of conversations with their peers, with other people, and with their written communication and communication within a school situation. And they can just be slow to learn new information and to keep up with vocabulary development, which for young people, particularly when they get into their teens, can be really, really important. And understanding all the new jargon, which many of us as adults quite often struggle with anyway, can be extremely important to be accepted into that peer group, which is extremely important. And it's important for reinforcing that young person's sense of identity. Next slide, please. So the knock-on effects then on social behaviour, and therefore their acceptance within a social circle, can be that they show rambling and tangential speech and problems sticking to the point. As I think Emily mentioned earlier on, young people can show very slow information processing, and that can affect both their expressive language and their receptive language. I also remember working with a young girl some years ago, and she had extreme problems with information processing. And in the sort of fast-moving world of a young person setting and a school setting, people would speak to her, and it would take her a while to process that information and understood what had been said to her. But then it would equally take her some time to consider her response to that as well. And so there would be, someone would say something and there'd be quite a long gap before she replied. And what we noticed was that often the person who'd spoken to her had just moved on, either in conversation or physically moved on, before she ever got the response out. And so it was, again, extremely frustrating and deflating for her, because she hardly ever got to actually respond to two-way communication like that. Similar to the sort of issues that I mentioned before in terms of the sarcasm and the jokes, you know, there's an inability to read between the lines or understand nuances or get the gist of a conversation, which again can leave you in a very kind of vulnerable and excluded state within the sort of fast-moving conversations in childhood. And I think Emily also mentioned earlier on the possibility of sort of socially unacceptable communication and insensitive to others' feelings. So people blurting out things which can appear rude and can appear in the way that a very young child or toddler might suddenly blurt out something that pops into their head, which you wouldn't expect of an older young person. Next slide, please. So then they are they can show then an inconsistent performance, and an inability to keep conversations going, and a problem in terms of changing topics. It can be quite difficult for young people to kind of move from one train of thought to another and to change topics. And also sometimes allowing others to express themselves, so to talk and talk and talk, and not allow anybody else to to come into a conversation. A number of people have referred to potential issues relating to executive functioning, the ability to kind of planning and organising and monitoring your behaviour. And so again, thinking about perhaps teenage adolescents, they are often in a situation where they may be under normal non-pandemic circumstances, planning on where they're going to meet, how they get in there. Then the young person has to think how they're going to get there and how they're going to get there on time. And if you have difficulty planning what you are going to do, then it can be difficult for such a young person to be able to engage in those sort of activities with their peers. And once again, even with the most tolerant young person, if they are arranging to meet a friend at a certain time and a certain place, and they don't turn up, then after a few times that happens, then they tend to find that they get invited less often. And the other thing that sometimes happens, as you can see, young people being unaware of other individual's personal space, so just being unaware that you're getting too close to people, and just generally behaving in ways that are deemed to be inappropriate, which again increasingly as you go through childhood and adolescent becomes a source of embarrassment to their peers. Young people can distance themselves from someone who appears to be acting in a way that they think is odd difficult, embarrassing or awkward. Next slide, please. So unfortunately, as a result of these issues that we've just been discussing, we are aware, and studies definitely show, that children and young people with acquired brain injury often report loneliness. And it's one of those things I think is really, really hard for families as well. I've worked with many families, and one of the things that just seems to be top of, or towards the top of the list in terms of parental concerns is that they have said to me, my child just doesn't seem to have any friends anymore, and it really, really upsets me. And then you have issues sometimes where parents have said, I've tried everything to engineer situations to get my child with other young people and to invite young people around, but it doesn't seem to work because they don't seem to interact well, and I don't know what else to do, and it just seems to make matters worse. So it is a huge issue, I think, for parents and families. I mean, we do see often that initially friends can be very supportive. So if a young person has an acquired brain injury, there's a lot of sympathy from their friends and a lot of curiosity as well. And initially they want to be really, really supportive. But unfortunately, after time, when faced with the sort of unpredictable and different sort of behaviour, when faced with someone who they can perceive as a completely different sort of person from the friend that they knew beforehand, it's very easy for friends then to drift away, to drift towards the group of people with whom they identify with, because they probably do no longer identify with the changed young person who has encountered an acquired brain injury. And of course, the social rejection itself that young people can experience can exacerbate the problems, as it precludes their opportunities to practice their social skills, because if they're not being invited or involved in social activities, then they're just not practicing those social skills, and so it can be a self-fulfilling prophecy, really. And of course, we know that young people who are lonely are at risk of poorer adjustment, really, within adult life. Next slide, please. So from a social perspective, really, too many of these young people, and the many hundreds I've worked with over the years, really do talk about seeing themselves as being different, and the feedback that they're getting from those around them and their peers often are reinforcing that difference that they see in themselves. And the quotation I've put here is old, but it's still very relevant, I think, and it relates to children with traumatic brain injury, but the same applies to any young person with an acquired brain injury, that they are often very well aware of themselves as being different and aware of the changes in them and their loss of abilities, which can be very hard. It would be for anybody to deal with, and particularly these young people can find that incredibly difficult. Next slide. This is just something as well from some research that Vicky Anderson and her colleagues in Australia have done a few years ago. I'm sorry that the slide hasn't come out terribly well. The vertical axis on the side, it says degree of deficit, but it's kind of squashed up over the numbers. But if you look there, they followed up some people, young people who were injured when they were quite young, and followed them up for 5 years. And if you look, that the degree of deficit, the neurological deficits actually decreased over the first 12 months, and then were fairly stable from thereafter. The degree of cognitive deficit gradually decreased over that 5-year period. However, the degree of behavioural and social deficits that these young people faced increased significantly. It decreased over the first year, and thereafter it continued to on an upward trajectory, which is I think is something that that we need to be very well aware of. Thank you. Next slide. And just, excuse me, just a number of other issues that I thought that are important for us to consider really when we're thinking about these young people. Emily also mentioned lack of awareness, and I think that is important. It's important to consider with young people, and I've seen this in ones that with whom I've worked, of whether they lack awareness of their deficits and their differences, or whether they are in denial of their deficits and differences, because the way that you would address those would be different, and they are very different things. A lack of awareness means that they actually do not understand those differences or deficits, whereas denial is a coping strategy. So it's a way of denying what they actually do know really, but they're coping with it by denying it. I think it's important to consider the young people's feelings of frustration and failure, whilst they are still considering themselves in terms of the sense of self, the sense of identity they might have had beforehand. And it can be very difficult to make that change to, this is how I am now, and this is how, these are the strengths that I have now. And also, of course, the potential for secondary mental health problems, which Santosh mentioned as well this morning. The potential for anxiety and depression, and potential for self-harm as well. As young people increasing, if they can't get out of that kind of cycle of seeing themselves as frustrated or failing or different and not fitting in and being lonely. And so it's important to be aware of that. And then I just wanted to mention the social media minefield really, because I think that a lot of young people are very vulnerable to falling down the rabbit hole of social media. I mean, something else I do as well as this is I work as a volunteer counsellor for Childline, and all young people really have a vulnerability to in terms of social media. But I think possibly that young people after acquired brain injury are even more vulnerable to being pulled into things within social media, to being possibly bullied, to being possibly groomed by ill-intentioned others, to being persuaded to post things, including photographs that might be inappropriate, on social media. So it's really, really important to think. I've seen many people who've got themselves into all sorts of problems through the fact that it is just so normal these days for children to engage in and have a presence on social media, but we have to be careful. And then again, I think Emily mentioned the one of these studies. I think that we do know that it's really important to engage the young person in what they want, how they're feeling and what they want and what goals they want to achieve. And as was mentioned earlier on, that there has been a couple of studies actually recently by the Children's Trust and the Cambridge Centre for Paediatric Neurorehabilitation, which just showed quite clearly how important it is for the child and young person to be able to define themselves what's important and what they want out of life and what goals they want to achieve. Next slide, please. If we think about what we're going to do in order to help young people with social skills, there are lots and lots of social skills programs and packages around. They tend to have been developed initially for people with developmental issues, and sometimes traditionally we assume that the young person lacks the knowledge of social rules and behaviours, but that's not necessarily the case for young people with acquired brain injury, because you will often find that they can explain these in a theoretical situation, but they just can't put them into practice. So some of the things that we have to do with these young people are different from young people with developmental problems who do not have or have not learned those social skills in the first place. However, it might be the case with some young people injured at a very early age that it will also apply to children with ABI. But so it's important to understand what the issues are. Next slide, please. So So how can we help? So the kind of, I think it's really important to, again, to think about working with a young person in real life situations. It's very, very hard for young people with acquired brain injury to generalize things from one situation to another. So if you actually work with somebody in a one-to-one situation, as I said, with understanding the social skills, for instance, then they can perform perfectly well. They know exactly what they need to do. But what if they can't do that in a real life situation? Then it is unhelpful. And so it's important to base whatever we're doing and however we're promoting the sort of skills to do so in a real life situation that's meaningful for the young person, and rehearsing and rehearsing. So as many different situations as possible to help them to compensate for the difficulties that they have. And then prompts to a certain extent. Again, it's really important not to draw attention to a young person, particularly if they're a teenager. I worked some years ago with a young man, and he tended to talk far too much, and he was in a situation, we worked in a classroom situation, for instance, around a table with a group of other young people, and he, in answering a question or proposing his views, would talk and talk and talk, and he and I discussed this away from everybody else, and we discussed what he would be comfortable with me using as a prompt to say to him, "You're talking too much now." And so it was just something quite subtle, a subtle movement, and that worked after, not immediately, but after some time it worked very, very well, because he would pick up those cues. And it got to the stage where sometimes before I'd go to move, and then he'd say, "Yes, okay, I know I'm talking too much, I'm stopping now." And gradually he was able to self-monitor. And then encouraging new interests or leisure pursuits, because as we've said before, a sense of identity is often rooted in those interests that young people had prior to their illness or injury. But often they can't engage in those anymore, and helping them to kind of be aware of what else they might enjoy, and finding somebody else who has similar interests, and helping them to do so. And so and then finally, really just information for an empowerment of their peers, but when appropriate. Once again, you can't just go and share information with a young person's peer group without permission. So you have to have permission really from the young person and their family if you want to share information and give information to their peers to help them to interact. Sometimes it's because they don't know how to deal with the young person with acquired brain injury, and they remove themselves physically because they don't know how to react. And if you can explain to them the difficulties that the young person has and how they might approach it, that can be helpful, but you must have permission from them first. And so also giving that young person opportunities to talk, to say what they want to do, what they want to achieve, and listening always and never judging. And then there is also that, obviously, that need, because teenagers particularly want independence and autonomy, and parents want to protect them, and so we have to be aware of that as well. I think that if I'll just sum up really, but while I do, if we just put the final slide up, which is just some social skills packages that are used in schools. For those of you who are based in schools, there are some packages that are used that can be useful for young people with acquired brain injury, as long as these are adapted and we are aware of the brain injury issues. So coping with change and difference is hard for anyone, and not least of which for children after encephalitis. And much of our supports and interventions can usefully be seen as like that recommended for any young person. So not to sympathise with them, but to empathise with them, and to listen and not to judge, and not to propose or impose solutions that we perceive might work, but to support themselves to manage change and to move forward in their path towards becoming a fulfilling adult, towards having a fulfilling life as an adult. Thank you.
Thanks so much, Beth. I mean, that was a really insightful, really particularly powerful talk, and I think you've kind of gone full circle today in the webinar, and you've kind of turned the lens, or certainly for me, on the sort of, you know, the feelings from the child and the young adults and the difficulties that they face. And, you know, as a human being, it's heartbreaking to hear, because those are things that we take for granted and obviously are very intrinsic to being human. So really thank you for sharing that, and I think it's, again, it puts a lot of things into context. So we're moving on to another short comfort break. So I'm probably going to recommend that we restart at 12:35, and then we'll restart with the last talk from Patrina Sill, Chief Executive and Founder of the Eden Dora Trust, and then we'll go into our question and answer session. So please continue to send your questions through, and then obviously we can then highlight those and discuss those at the panel discussion. So thank you very much. And again, we're going to just share one of our other stories from the Eden Dora Trust about another lovely young girl that the charity have managed to help. So thank you. Hello, welcome back, and hope you've all been suitably refreshed on the second break. I've now got the pleasure of introducing Patrina Sill, who is the founder and Chief Executive Officer of the Eden Dora Trust. I've known Patrina probably for 7 or 8 years now, so I've had the pleasure of knowing Patrina both professionally and personally, and I've seen the sort of power and passion this young lady has, and what she's done in terms of obviously what turned out to be a first-hand experience as a mother whose child developed encephalitis, into actually seeing the help and support that families needed. And obviously she used that to obviously create the charity, the Eden Dora Trust. So Patrina's going to talk to us about what the charity offers, some of the fantastic initiatives, particularly the recent initiatives the charity has undertaken, and the help and support it can offer both to children, families, healthcare professionals and educators and the like. So I have much pleasure to hand over to Patrina. Thank you.
Thank you, Julianne. Well, as Julianne said, I'm Patrina, and I'm the founder and CEO of the Eden Dora Trust for children with encephalitis. I'm here to talk to you today about who we are as a charity and why we are so happy to be running this study morning. Firstly, I'm going to talk briefly about who the Eden Dora Trust are as a charity, then about the importance of the return to education in the journey of a family who are facing encephalitis and ABI, as well as one of the really exciting new projects that we've been working on called the ABI Aware School Award. And then finally, I'll discuss in some more detail exactly how we as a charity help children and families across the UK. Next slide, please. The Eden Dora Trust for children with encephalitis is a charity with a highly personal touch. In 2011, when my daughter was 6, she had encephalitis. She had the symptoms of a slight cold, but seemed otherwise okay. I kept her off school just to be safe, and she ended up having seizures before falling into a coma, and we were rushed to hospital. The specialists eventually discovered that she had encephalitis. That was the first time that I'd ever heard that word. When she eventually woke up, we learned that she'd had an acquired brain injury, which left her needing to relearn to walk, talk and write, as well as altering her personality and affecting our lives as a family ever since. This personal experience is at the core of our charity, and that means that we can be a place that truly understands the needs of the children and families that we support. We're the only charity in the UK dedicated solely to supporting children and young people with encephalitis, and at the heart of everything we do is our mission to ensure that no other family ever has to go through encephalitis and acquired brain injury in the same way that we did, feeling alone, confused, misunderstood and scared for the future. Next slide, please. As our amazing professional speakers have already discussed today, after having dealt with an often long and incredibly difficult stay in hospital, the next major step for children with an ABI is returning to school. This return to education makes up a large part of their rehabilitation process. However, a key issue with this is that sadly there's no mandatory training, as we've discussed earlier, for educators into encephalitis or acquired brain injury, meaning that there can be a huge disparity between schools in how much or how little knowledge their staff have about what ABI is, how it affects children, and how they can help support them. Sadly, this means that the process of returning to education can often be one of the most stressful and difficult parts of dealing with encephalitis and acquired brain injury. We've always known that educators have wanted to support all of their students in every way that they can, but we also know that doing this can be incredibly hard when you haven't got access or had access to any training or resources about something as complex as encephalitis and acquired brain injury. And this is something that we as a charity have been working incredibly hard on. Next slide, please. In order to address these issues across the nation, the Eden Dora Trust have worked in collaboration with the wonderful Child Brain Injury Trust to create a fantastic new initiative known as the ABI Aware School Award that we've just launched. We're very, very proud to say that we fund this in its entirety, and essentially by completing this award, schools will be demonstrating that they've accessed a rigorous course of training into understanding what ABI is, how it affects children and how they can best support those children in school. Ultimately, the award will be helping to foster a school environment where children with encephalitis and acquired brain injury can not only survive, but truly thrive to the best of their academic and social ability. Next slide, please. We can understand personally at the Eden Dora Trust that dealing with encephalitis and ABI is an unimaginably difficult journey. And we know that after dealing with so much already, families really do deserve the reassurance of knowing that their child will be returning to a school that has been trained to understand their child's new needs. You can find out a lot more information on both our websites and download this leaflet too. You'll be able to get this in the chat function on the screen. Next slide, please. As well as this incredible award, following the recommendations made in the all-party parliamentary group for acquired brain injury and neurorehabilitation Time for Change report, the National Acquired Brain Injury in Learning and Education Syndicate, ENABLES, was established, and we're really proud to be an active part of this fantastic steering group. The purpose of ENABLES is to ensure all children and young people with an ABI receive the support that they need to maximise their educational potential. Two of the main aims of the group are to identify and share good practice in support of the education of children and young people with an ABI, and increase awareness and understanding of ABI within the education system. Next slide, please. Alongside these initiatives, we also fund and run so many other projects as a charity. For example, professional training workshops, research and literature into understanding encephalitis and ABI, study days like this one today, and personal support and advice for families affected by encephalitis through every stage, from diagnosis to rehabilitation and beyond. We have lots of brilliant resources on our website, like Getting to Know our Childhood Encephalitis booklet. You can view and download all of these for free, or get in touch with us and we'll send you hard copies for home, doctors' surgeries, hospitals, schools, or anywhere that would like one. You'll find lots of informative stories written by some of the families of children we support on our website, like the one on the screen here by Matty's mum, Layla. Here's a short video for you to watch with some of the brilliant professionals that work with the Eden Dora Trust, giving some insight into what we do as a charity. You might need to turn your volume up here.
The Eden Dora Trust is a charity. It's the only one of its kind for children with encephalitis. It has a really important role in providing support for families, in providing education, not just for children and their families, but also for health and education professionals, to ensure that the outcomes for children with encephalitis can improve going forward.
About 6,000 children every year get childhood encephalitis, but we often find it's quite low down the differential diagnosis when someone presents their GP and their hospital. And we want to make sure that if we raise the awareness, then we can ensure that individuals get timely treatment, which will hopefully reduce the long-term outcomes and disabilities that some of the children will sadly go on to suffer.
So a child can just be off color, or they could have not their usual self. And if it's not picked up and raised awareness very much in the community, it can rapidly go downhill and cause a very serious problem. And the reason for early recognition is that if you recognize early and diagnose, the treatment can have better outcomes.
These children, when they have a diagnosis of encephalitis, can experience all sorts of problems, from behavioural, cognitive to motor deficits. And we know as children get older and bigger, those problems stay with them, and therefore these families and children need lifelong support.
The work of the Eden Dora Trust is of vital importance to the adjustment, not just of the child, but of the family itself.
The child's brain is so undeveloped, and something like this can just ruin their lives, and if it's more understood, it's easier to help them recover and be there and support. I was in hospital for 3 months, in a coma for 6. Whilst in a coma, I got a blood clot in my bowel, which resulted in me having a colostomy bag whilst in a coma, and for 1.5 years after I recovered as well. The Eden Dora Trust helps parents come to terms with that, and I wish that my family had that support when I was ill, and knowledge as well, because they didn't know anything about the illness.
So, As you can imagine, COVID-19 has had a huge impact on our ability to raise both funds and awareness in the wider community. However, children and families across the UK have needed even more support than ever as life has continued to change so rapidly. Without the support of people like yourselves across the UK, we would not be able to continue the vital work we do every day to support so many children and families. Whether it be in the form of personal or workplace fundraising, stocking our informational materials at your workplace, social media interaction, or attending our events like this one today. It all makes a massive, massive difference. We've got lots and lots of virtual and COVID safe ideas for fundraising, as well as ideas for normal in-person fundraising available on our website if you'd like to help us. Next slide, please. Thank you so much for listening. I hope I've given you a sense of who we are as a charity, what we do to support children and families across the UK, and why the work we do and the support we receive is so vital now more than ever. For more information on encephalitis and acquired brain injury, or to find out more about what we are currently doing to raise funds and awareness and how you can get involved, please visit our website at www.edendoratrust.org. Or feel free to telephone or email us. And I'll now hand you back over to the brilliant Julianne for our Q&A. Thank you.
Thanks so much, Katrina, and hopefully that's given you, who I know a lot of people already know about Eden Dora, actually, you know, what we as a charity do and obviously what we can offer. And I think importantly, what we've seen in the sort of last year is real that kind of focus. We've seen the impact, particularly of COVID, on education, and we've always known that's an issue following a diagnosis. So, you know, the fantastic work from Katrina and the charity and the other charities that we work with to, you know, have those resources, etc. You know, please do share those with your contacts, schools, etc. We're here to help. So on to our final section, which is our Q&A. So we've had some questions coming through, so I'll attempt to be question master, and our lovely panel of speakers will hopefully be able to provide a response to those. So I'll try, where I think it's applicable, to direct those questions, but as I say, some of our panelists may also want to jump in. So I'm just going to move on to the first question that we've had, and this is from one of our delegates who's asked me to ask this question. So my son was diagnosed with ANEC, secondary to influenza A, in 2018. My siblings and I have a medical history of an autoimmune diseases like ulcerative colitis, SLE, which I think is lupus, rheumatoid, thyroid problems, etc. And they would like to know whether there's a chance that their son's autoimmune disorder might have attacked his brain at that time. So I don't know, that might be one for Santosh.
Okay, I mean, the thing with it, I mean, ANEC is acute necrotizing enteropathy of childhood, if that is the one. I mean, there are various causes for it. There are various viruses implicated on that, and I presume it says that, I mean, it said that it was because of secondary to influenza A. That is a commonest virus, but there are other viruses also which can cause that. Very rarely, there is only, I mean, looking at it, there is only one genetic cause for it with the association of a gene break called RANBP2 gene. But I don't think that is associated with ulcerative colitis and SLE. I may be wrong, but I don't think that is associated with that. But if the child has got ANEC, and if he has made a reasonably good recovery, it depends upon recovery, as I said, is two parts, a physical and cognitive recovery, which is there. But I don't know how old the child is. That is what will need to be found. That will tell us whether it has had an impact or physically or cognitively on this child. I hope, I mean, this is because there's only limited information. Julianne.
Thanks very much for that, Santosh. So our next question, I think this one might be for you, Heather, and it states that my son has a nocturnal sleep pattern. He can't fall asleep easily at night, and I have a problem waking up early in the morning, or he has a problem waking up early in the morning. Please, may I know why that is?
Yeah, so it sounds as though you're describing a shifted, what we call a shifted sleep phase, which is where the child sort of becomes habitually sort of so that the sleep is just kind of shifted a few hours from what you would normally expect it to be, and that is usually caused by something that's interrupted or disturbed the sleep onset time for whatever reason. And I think for all the reasons I listed in my talk, to do with disruption in hospital, disruption of the sort of the 24-hour cycle due to, you know, having a prolonged stay in hospital, and other things that can impact on the child's ability to fall asleep, like anxieties, fears, physical reasons, etc., can sort of just mean that they have difficulty getting to sleep, and then because it takes them longer to get to sleep, then they wake up later. And so what then results is that the body sort of just gets into the habit of going of these new sleep times. And what's needed, I think, I mean, it's very individual, so I don't know what's sort of, you know, relevant to your child in particular, but what we would do would be to sort of do quite a detailed assessment of what's happening in the lead up to falling asleep, and see if we can then just reset the sleep wake pattern, so that we bring the sleep time forward in time. And sometimes that involves resetting the wake time, so it's easier to wake somebody up than to help them to get to sleep. So sometimes it involves you know, just setting a very, very consistent and regular wake up time, and sometimes it involves also addressing some of the issues around bedtime to try and help the child to fall asleep more easily. I hope that helps.
No, definitely. I mean, I don't know, just from what we've seen as well, do you think it's also helpful for families when they've got children that have sleep disorders and difficulties, before they approach professionals like yourselves, that actually it helps you to encapsulate some evidence by keeping sleep diaries and looking at how often they wake up, what time, you know, how you get them back to sleep and those sorts of things? Is that quite useful information for families to keep for you, Heather?
Yes, definitely. I mean, sometimes keeping a sleep diary actually, you know, it actually makes the problem apparent to you, you know, without actually needing to seek professional help. And sometimes if you do need to speak to a professional, it can be really helpful for the professional to be able to see what the sleep pattern actually is. So keeping a sleep diary over a period of about 4 weeks is really helpful, and then you can sort of start to pick it apart and address the individual factors. Yeah.
Thank you. So my next question, I think it's for the Emilys. And the question is, children have missed so much school time during lockdowns, and it seems to have had a huge impact on my child with fatigue, their peers and socially. They now say they're too tired to see their peers, as it takes too much out of them. Any advice? So it might be both the Emilys, but also Beth might be able to respond on that.
Yeah. So I mean, I think obviously for all of us through lockdown, I think that adjustment to getting back to things is quite hard anyway. But for young people with fatigue and with these difficulties, and understandably that's hard. And I think sort of talked a little bit earlier about that kind of balance of activities and things, that actually getting back to school is a huge thing for these children who've been through this lockdown period. And I think actually balancing for us, what we would be doing is having those discussions with school as well, a lot about actually learning's really important, but actually the social side of things, the importance of that for children's self-esteem, for their confidence, just for their ability to kind of develop those social skills is you know, massively important. And so actually sometimes it might be about them taking the pressure off them from a learning perspective during the day at times, so they've got that ability and that capacity to engage in those social activities as well.
I think when we talked about pacing earlier, it's important that pacing incorporates all the different activities in a child's world and all the different things that matter, isn't it? And so, like we said, you know, if you're going to think about what's a green activity versus a red activity, for example, and trying to balance those throughout the day, It is important that there's some things that are physical, some things that are social, some things that are cognitive and so on, and just trying to make sure that, that a child's world includes all of those things that we know are so important.
And I was just thinking as well, obviously, talking about, they're too tired to see their peers. I think there's also that balance of, for a young person post ABI, it may actually be difficult in a group situation anyway, from a processing speed point of view, from a concentration point of view. So actually thinking about how overwhelming, being in a world where you've actually just been at home with family, even just seeing one friend might be quite overwhelming in some respects. So just kind of those social contacts, just phasing those in. So, it might not be about meeting up with 6 friends all in one go, but just kind of, easing that in gently with meeting with one friend for a short period of time.
Yeah, I mean, I agree with with everything that's been said, and I think that possibly, particularly that business about talking with the school and trying to manage the timetable during the day, but also possibly even modifying that school day initially, and thinking about building in some rest times or going in less initially, thinking about which parts of the timetable are the most important and which parts aren't, in order that the child or young person is getting enough rest during the day. So but yes, and definitely the idea about perhaps less friends at once, and to choose who that is, which is also quite important, really. What demands are going to be made of that young person depending on who it is that they meet, and they gradually perhaps going to get more confidence and more motivation as they if they have a good encounter with one chosen friend to start off with, because that can add to their fatigue as well. I think they can feel that they are too tired, but then also possibly that they don't want to engage with their friends if there are issues that are going to come up when they try to do that.
Thank you, everyone. So another question we've got actually arose during Katrina's section is, could there be guidelines or suggestions and references for homeschooling children with encephalitis? And this particular question is posed by someone whose son is 15 years of age. So it's about guidelines, suggestions and referencing for children who are homeschooling and have encephalitis. And again, that might be a question for both the Emilys and Beth and Katrina.
It would be, I was going to say, it would be interesting to know why the young person is being homeschooled. Again, again, with thinking about all those social issues that we have talked about, it is important for young people, to mix with other young people. So, there could be guidelines for homeschooling, but I think built into that, you'd have to very carefully think about, how they are going to be able to maintain social interactions and social skills in that sort of environment.
And I suppose we were just wondering as well if that's generally homeschooling or homeschooling in relation to COVID or as well.
Thank you. I mean, I think we've seen, haven't we, parents with children without ABI, parents with children with ABI, the impact really that COVID's had, particularly on, children, schooling generally, but, there's been a significant impact as well, hasn't there, on children with acquired brain injury in terms of obviously having access to support, education, and also the impact of remote learning. I mean, is there any advice that you can give to parents in those situations, sort of, and the impact of COVID and what they need to really concentrate on and what they can concentrate on with the school, and to sort of get them back into that classroom learning?
I mean, I think from my perspective, a lot of schools, the focus has been on mental health and social integration again, because I mean, I think that's been the main idea. It's not necessarily in practice always been what's happened. I think there's been some element of pressure depending on the year group, whether they're a kind of GCSE year group or what have you. But I think a lot of schools have seen and acknowledged the need for that focus on the social side of things, on the mental health side of things. So, and I think that for us, I think would be the main focus, is that in order for them to be in the right place to engage with the learning side of things, they have to feel confident and okay about being in that school environment. So that's one of the biggest things, is just getting over being in school, being around other people, being back with their teachers, and feeling able to engage in the learning process.
That's really helpful advice. Thank you, Emma. Beth, were you going to say something?
No, I was just going to say, I think it's also important there's often an emphasis, and I've heard that in what people have talked about recently in the media and so forth, about young people and the effects of the remote learning and the effects that has been the case since we've had the pandemic. But they focus a lot on teenagers sometimes, and I think it's also important just to remember that there has been a huge impact as well on younger children. And it's easy to focus on, particularly with mental health issues and the way that this has affected them and their friendships, whether they're children with acquired brain injury or not, throughout primary school as well as secondary school. I mean, if I think my own grandson, who is 5, was going into school, and I mean was homeschooled for, as so many children had to be, and then started going back into school. And the first day that people were allowed to meet in groups of 6 outside of school, he wasn't told in advance, but when he came out of school, his mother said to him, well, we've got a surprise for you, because you can now go and play in somebody else's garden. And he was so excited about it. First he had to run in and tell his teacher, but then after that, as he was going to the friend's house, he said, can I really go? Can I go in real life? And I thought it really does just show that the way that children have come to view the world, and if you are very young like that, the way you view the world has been so different over the last year in terms of contact with other people. And so, even more so with young people with ABI.
Yeah, that's really helpful. Thank you, Beth. So we've come towards the close really of our webinar, and just before I hand over to Petrina, who wants obviously to say thank you and close the seminar, just a reminder that we will be sending a feedback link, and we'd be really grateful if you could complete that. It should only take a couple of minutes. Just give some feedback on today's webinar, and also what you might want to hear going forward, because we'd really be keen to sort of continue on with this series. So if you can complete that. So I'm just going to say my thanks to everyone and everyone attending, the speakers, but most importantly, I'm going to hand over to Petrina now, who's going to close the webinar. Thank you.
Thank you, Julianne. Well, from everybody here at the Eden Dora Trust and from everybody involved, thank you everybody so much for attending our study morning today. We really hope it's been a useful and informative session for you all. As Julianne said, please do complete the feedback form, because that will help us in the future with what you'd like to have covered. The link will hopefully be in the chat box at the side. We'll also send that out to you afterwards. Of course, this session would not be possible without all of our incredible speakers who've given their time to present today. And we'd like to just say a huge thank you to every single one. It's just been fabulous. And of course, as well as everybody at Owen Mitchell, who have been so brilliant in hosting the webinar today. Thank you all. Please do visit our website to access all of the free resources on childhood encephalitis and acquired brain injury. If you're someone who is affected by encephalitis or acquired brain injury, then please do send us an email or telephone if you need any support or advice at all. We're always here to help whenever you need us. If you have any more questions, please don't hesitate to drop an email or, as I say, give us a call. Thank you so much for listening, and goodbye.